Do I smell lavender? I think the hotels industry already knew about this lavender thing. Because you walk into the lobby and you have this scent, and I think it's lavender, and you like drive through LA traffic, pissed off at the world, and you walk in, you're like, ah, lavender. Anyway, hope everyone had a really great lunch. Thanks for coming back. We have two beautiful speakers to share their stories. So without further ado, I believe Camilla, you're going to go first. Yes. So I'm going to give her the podium.
Is this on? Okay, it's on. Good thing we weren't talking about anybody in the room just now, right? Just kidding. Hi, my name is Camilla Row, and I am a stage 4 patient. I have spread to the peritoneal cavity. My journey begins in 2018 when I was diagnosed with stage 1 disease. I was diagnosed after complaining about reflux pain, which I experienced for approximately 2 years. It was only after my 3rd gastroenterology referral that I was offered an emergency endoscopy, which was scheduled for 3 months out. And once that was completed, it was confirmed that I had a flattened lesion. It was 1.9 centimeters and only on the first layer of the stomach. So they sent me straight to surgery, and I had my total gastrectomy 4 weeks after I was diagnosed. Upon getting the pathology results back, they told me 2 local nodes are positive, and that upstaged me to 1B. I did all the recommended treatment. I did the mop-up FOLFOX, and then I was declared NED, and I had a lot of assurances from my team and assurances from data that my chances of recurrence were very low. Spent about 3 years just trying to find a new normal and resuming mom duties. Went through COVID and like 18 months of homeschooling my kids, which I just, I won't go into that. In 2020, I incorporated the use of a ctDNA monitoring test, the Signatera, and that's what alerted me to the fact that a recurrence was coming. So in the summer of 2021, my Signatera was positive after I had a string of negatives, and in that moment, I knew something was coming. Now, people have asked me, man, you are a glutton for punishment. Who would want to know cancer's coming? And you're like sitting there thinking about like, when is it coming? Where is it coming back to? Because we did all this, the scans, the PET, I did an endoscopy, everything came back clear. The only thing I didn't do was a laparoscopy, because it's invasive. But there's no guarantee that there would have been anything found at that point anyways, because the disease is microscopic, right? So I sat on that information for about 5 months. And then in December of 2021, a routine routine CT scan. And now I'm at 3.5 years post-treatment for my stage 1 disease. I was told that I had masses on my ovaries, and I knew in my heart of hearts that those were Kuchenberg tumors. I mean, I try to lie to myself, and I'm like, oh, maybe it's PCOS, maybe it's fibroids, but And even my oncologist's like, your pelvis is like a hotbed for, stuff, so don't think it's automatically cancer. But I knew, just in my heart of hearts, like I fit the profile. I'm a premenopausal, I had signet cell adenocarcinoma, which is highly aggressive. So in my heart of hearts, I already knew those were Kuchenberg tumors, and that sent me. So I skipped ahead, stage 2 and 3, and I just went straight to 4. So 1 to 4. So And at that point, I had been talking to my original surgeon who did my gastrectomy, and he referred me to a gynecological oncologist who removed my Krukenbergs 2-3 days after confirmation. She scheduled me on a Saturday. Young woman, she had a 5-year-old, and she told me if these were in me, I would want them out now. So I met a wonderful surgeon who acted fast, and I'm so grateful for that. After that, I looked into HIPEC. UCLA was not offering HIPEC for gastric cancer. They do for colon, ovarian, appendiceal, some other ones, but they said the data was mixed on gastric. It's not something that they offered. And Aki and Jason introduced me to Dr. Wu. And I met with her. Well, they told me about her, and she called me like an hour later. So it was just wonderful to have somebody so proactive and passionate, and I was able to talk to her openly, and she offered, she conceptualized my disease from a different angle, because I consulted with other HIPEC surgeons who did not offer me the out-of-the-box thinking that Dr. Wu offered me, and so I always tell her that I owe her my life. And it wasn't easy for us. I had to argue with a medical oncologist at City of Hope who would not clear me for HIPEC. He wanted me to just he wanted me to do 6 to 8 sessions of FLOT and then reevaluate. Not even 6 to 8 sessions and let's do the HIPEC. It's like, we'll just reevaluate that at that point. But knowing this disease, you have windows of opportunity. And I felt that I had timing on my side because I was able to catch it so early with the ctDNA monitoring. And that's why I urge all of you to argue with your doctors, contact Signatera or Natera directly, enroll in one of their patient programs, speak to their reps, and get that buy-in from your oncologist, because at the very minimum, you can use it. Maybe it will help guide your treatment monitoring. It's not just for surveillance. I think you can get creative with the data that it provides. So I just consider myself lucky because I use a Signatera. I met Dr. Wu. I eventually was able to get the HIPEC in June of 2022. We ended up doing a whole bunch more. But I think I am evidence that I've had 6 HIPECs. I'm evidence here that you can have this many HIPECs and be a functional human being as I am. I'm still able to function as a mom. I don't have a nanny. I have a 9 and an 11-year-old. The 11-year-old, I may send to boarding school soon, but boot camp, military, I don't know. We haven't decided yet, or therapy. But I just consider myself so blessed to be able to be here with you and share my story, because I have, with the addition of HIPEC to my systemic treatment, I've been able to experience months and months, periods of no disease, minimal disease. And I don't think that would have been possible if I had just done the systemic therapy alone. I was doing nivolumab. I don't have any biomarkers. My oncologist said, let's just take a chance. And I'm convinced it helped. I didn't think it hurt me, and I was one of the lucky ones that didn't have many side effects. So I was able to receive nivolumab for about 18 months, and I did like maintenance. I am doing Full Fury right now. It's done in an abundance of caution. Dr. Wu is able to resect the new lesions that were found, but just again, I consider myself blessed that I'm healthy enough to withstand the treatments, and that's why I'm doing Full Fury for the things that she's not able to see, the microscopic disease that we all fear and know so well. So with that, thank you for listening to my story, and it's just a wonderful honor and pleasure to be here with all of you. And I know I've heard this many times throughout yesterday and today, but this just feels like family, you know? I mean, there's the crazy uncle, there's the aunt that talks too much, you know, the one you're like, I don't want to be cornered with her. No, I'm just kidding. But it's just lovely to see the familiar faces and then meet the people that I knew virtually, and finally meet them in person. So thank you so much.
Thank you, Cami, so much. Somebody put the tissue box right here because they know that I'm a, I don't know, but it's not happening yet, so we're good. We're going to hold questions for the speakers until, Rachel, do you want to give your story as well?
Good afternoon. I'm really happy to be here with all of you guys this weekend for this event. Like Camilla said, this is my first in-person event. This is the first time I've been able to gather with a group of stomach cancer patients and just really share and learn from each other. So I'm really honored to be here with you guys, and it is just a really sweet feeling. My story is, I'm Rachel Orth, by the way. I don't know if I said that. I'm a little nervous.
You're doing awesome.
Thank you. A little bit of my story. I was diagnosed with stage 4 cancer in December of 2020. I got my diagnosis in the middle of the pandemic and knew nothing about stomach cancer. So we went through this whole process of trying to figure out what treatment would look like for us. And then eventually I did end up getting to join a clinical trial. So I just wanted to talk a little bit about those experiences, what that's been like for me and for my family. Before diagnosis, I was healthy and active. I have an amazing family. My husband's here with me this week. Caregivers are so important. I would not be here today without his persistence and his pushing for answers and for better treatment for me, and his support. We had 3 beautiful children. Their ages are 12, 9, and 6. And they kept me active. I had no health concerns really at all. I was 32 years old. I did the things I knew to do. I ate well, I exercised, I drank the water, I went to my well visits. I had no known risk factors. I didn't drink or smoke. I had no family history. I had no symptoms. I went in for my annual well woman visit, and that is when, during a pelvic exam, she felt a mass on my ovaries, and that was my first indication that there was anything wrong at all. So we moved forward. We had imaging done that confirmed I did have a tumor. We did blood work. We were concerned about ovarian cancer, but that blood work came back showing that I was very low risk. So we were like, okay, this is probably a benign tumor. We're going to move forward with surgery, take it out, on with life. It was after my surgery that I woke up to the news that my world was turned upside down. The tumor was malignant. They had to remove both of my ovaries, and there was further evidence of disease throughout my abdomen. The stomach lining was thick, and they took further biopsies. The working diagnosis was probable stomach cancer, which is something I had never even heard of before. So we went home, and it's hard for me to express what those next few weeks looked like for me and for our family. I was recovering from surgery. I was thrown into forced menopause. We were isolated because of COVID. And we had this huge unknown in front of us. I had my first oncology visit over Zoom, and that's when I received my official diagnosis. It was signet ring cell adenocarcinoma of the stomach with spread to the omentum and the ovaries. I was told that the disease is aggressive and that my diagnosis was considered terminal. A few weeks before being perfectly healthy, to suddenly having someone telling you that you're going to die from this cancer, it was a lot to take in, a lot to process. I asked about my treatment options, and I was told that I was not a candidate for surgery because of it being stage 4. I was not a candidate for radiation. There were chemotherapies available to me, but those are limited. He encouraged me to pursue clinical trials and to take the time that I had while I was recovering from my surgery before I could receive any treatment to seek out multiple opinions, reach out to a larger cancer center for newer treatments and clinical trials. So that's what we did. We took those weeks, we got online, we immediately started looking for support and community and information about this disease. We got a lot of scary information. And we also sought multiple opinions locally, and we did go to MD Anderson. That's when I was presented with the possibility of a trial for the first time. We started the qualification for that. I was a new cancer patient. I was very naive. I did not understand the qualification process. I thought, okay, you have a trial, I'm a patient, let's go. But there are things that you have to do to qualify for a clinical trial. You have to have certain biomarkers. Sometimes you have to have different proteins. You guys know this, but I did not. So we started the qualification process, then the testing and the paperwork. We started thinking through the logistics of what it would look like for us to travel back and forth to Houston for treatments. And it felt really overwhelming, but we were really hopeful as well. I did not qualify for that clinical trial, and that was devastating and frustrating. I felt like I was back at square one, and at that point I had recovered enough that I could start treatment, and I was very anxious to do so. When I had heard my prognosis being so poor, I was just anxious to do whatever I could. I just needed to do some kind of treatment. So that's what we did. We did FLOT chemotherapy. Before we started chemotherapy, we wanted to do some more diagnostic things just to get a good baseline. I had my laparoscopy, colonoscopy, endoscopy, and it was a few days before those appointments that COVID hit my home. My husband became symptomatic and tested positive for COVID, so we isolated him and we postponed my appointments and prayed that we'd stay healthy. About 10 days after his positive test, a few days again before my appointments, is when I became symptomatic and tested positive for COVID. It was a bad month. It was a really bad month. We did eventually heal. I was able to pursue my treatment, and we started my chemotherapy. I did 8 rounds of FLOTs and tolerated it pretty well. We did FLOT chemotherapy. The hope was that being more aggressive, I could potentially become a surgical candidate. I did not get that strong response that we hoped for. My scans were stable, but we did not see any regression. So we began looking at what my next line of treatment would be. We again pursued clinical trials. We talked to MD Anderson, and they presented me with 2 possible clinical trials. We immediately jumped at that opportunity. Again, now aware of what that process looked like, we started the testing and the paperwork. I did not qualify for one of the trials, but I was accepted into the other one. and that has been my second line of treatment now for 2 years. And up until very recently, my scans were completely stable. Now we might be seeing a little bit of microprogression, but 2 years is a long time to be in that position. For someone like me who is diagnosed stage 4, at the time of my diagnosis, my son, my youngest, was 3 years old, and I was preparing not to see him go to kindergarten. He's in 1st grade, and I'm active in his life. Sorry. I'm going to his field trips. Thank you. They put them at the wrong end.
They put one over there too.
Oh, well, it's hiding behind the flowers. I'm able to be active in his life. I'm going to his field trips. And I believe that is to a large degree because I had access to this clinical trial. I'm really passionate about clinical trials. I think that they're really important for patients like we are who have limited options. These are new treatments. We need more treatments. We need better treatments. And for that to happen, we need to have clinical trials. For clinical trials to happen, we need funding and education. We need awareness. And so that's why I'm here today telling you a little bit of my story. I just think it's really important to have clinical trials and for those clinical trials to be accessible to people. So thank you for listening to my story.
Jill, thank you so much for sharing this. Thank you. We can take some questions from the floor. I have a couple I wanted to ask the speakers, but I'd like to have someone on the floor ask if you have. Emmy, you have a question? Did you have a question? Okay. So I have a couple of questions. During your journey, was there a point in time that you said, "Oh, I need a champion," or "I need to designate someone to advocate for me," or were you advocating for yourself in terms of making the treatment plans, looking for treatments, doctors, clinical trials? Is there someone that helped you along that maybe, give you energy throughout? Or is this a solo kind of effort?
Do you want to answer?
You want to?
Well, I can talk. Yes. Especially in the beginning because it was also new and overwhelming. And I was going through a lot physically as well. I really heavily relied on my husband to help be an advocate for me. He's the one that set up the appointments. He's the one that drove me there. He's the one that would take notes. And I also had a lot of family who was doing research for me. I didn't have the brain capacity to do that. I do wish that I had more. I wish that existed more in the medical field, I guess, that there was someone on your team from the very beginning, like, you've been diagnosed, okay, I'm your person, these are the things you will probably be needing. Yeah. I didn't have an idea of what questions to ask. I knew nothing. Stomach cancer was a completely new concept to me, so.
I think those that know me know how obsessive compulsive I can be. So for me, when they denied me, I wanted to start my treatment with a high pack, and once they denied me and told me to go on FLOT, all those days I spent sick, I was probably on Google. So for me, I told my husband, I go, you just sit there, look pretty, and support me, and I will do all the nerdy stuff. But for me, I did it because, not just for selfish reasons, but for me, like I said, it's a coping skill for me to understand the disease, to understand the data. I know it's scary, but for me, I want to know, I guess, the reality. And knowing the reality helped me, I think, look for more aggressive treatment, something out of the box, because I knew if I just relied on what they were going to give me, which is the standard of care, I was looking at, I think they told me 12 to 24 months is what they told me. Similar? Okay. But I'm here, and I'm almost, 20 months out from my stage 4 diagnosis. I am currently no evidence of disease on scans, on all my pathology, on my cytology, and last Friday they told me that my Signatera was negative. So across three different, and like I said, I'm like, well, if my Signatera is positive, then I'm not NED, and I use that term very loosely because I am kind of always coming in and out of an NED status, I guess. I go, something pops up, she's like, cut it, burn it, strip it. And so for me, I really took charge of doing the research, not just to find out that information, but like I said, I figured if I'm able to like intellectualize this in some way, it kind of felt like work, you know? It kind of felt like work. Like, it's not my disease, like I'm doing this is like my job, I wanna help the stomach cancer community. And really, if I just kept this information to myself, I felt selfish. I'm like, I gotta say something. And so that's kind of what led me into doing all the advocacy work that I do now. And I'm so fortunate that I've had like a warm reception from all of you. I mean, I'm sure there's some people that are like, she's just a know-it-all, or who knows. But just very fortunate to be in this position, and for me, my self-advocacy has really made a world of a difference. So, and that's not to say I didn't get like emotional support and just psychological support from my husband and my mother, my brother, and also very spiritual. I lean on my religion and my church, and to know that I have that has also been very comforting for me. Yeah. So thank you.
Thank you. So the theme of our patient empowerment summit, I think, is talking about community, of your support community that you build, and listening to both Cami and Rachel and many others during the last 6 to 8 hours. That community is very important, and the way you build it, but we need it, whether you are intellectually independent and want to make those decisions, or whether you are more inclined to let others help. But I believe that it's very important to build that community. And then talking about translating this, the support community that you build among friends and family, there has to be a link also to the person in the hospital system, the care team. And one of the things I think maybe people out there can also address is the navigating the healthcare system is extremely difficult. I cannot imagine, and I hear this all the time from our patients, where do I go, who do I see, who's gonna tell me what's next, how do I process all this information? And some cancer centers have good navigation, but not all of us can go to a large cancer center. So I think that's something that we need to also think about. I had another question that I think maybe Lauren has highlighted during her talk, is how did you, or if you share this information about mom's sickness or a new diagnosis with your children, and what kind of support do you have to, help them cope with this while you guys are getting treatment? Do you want to address?
When I was first diagnosed in 2018, my children were 3 and 5. So I didn't share much with them other than, mommy's sick, mommy has to have a huge operation. She has to get her stomach removed. They're like, why? I'm like, these bad germs are in there that just, we got to get them. They got to go. So that was kind of the extent. And then when I had to do chemotherapy, it was just very basic. I have to take some medicine. It's going to make me very sick, but it's going to kill all the bad germs. Now they're 9 and 11, and my son's like, "Oh, was that Dr. Wu that called? Is this about your tumor?" It's just crazy what details they pick up on, even though I've never officially said, "Oh, Dr. Wu is my surgeon," although I did show them the billboard. And now they do know that I have cancer. They do know that I am stage 4. And we talked about the possibility that this is what could cause my demise. But I also left it open because I am doing so well. And they see a mom who's present. They see a mom who's there an hour before school gets out so I can avoid the bad car situation. Mm-hmm. Every day they see me. I take them to jiu-jitsu, to Kumon, to soccer, we just did a Vegas run last weekend. Awesome. So I'm able to stay active, and I think that in itself might be confusing because they're like, "Oh, well, you're sick, but you're still a mom. You're still doing what your mom duties, right?" Mm-hmm. And so I think that has actually maybe prevented me from talking about the details or the gravity or the prognosis I've been given. So I've left it open-ended. I feel that when the time, if the time comes, like they will be at an age where they can grasp the concepts better than if I had the conversation with them at a younger age. So that's, I don't know if it's right or wrong, but that's just how it's happened for us.
We were just talking about it actually before. So at my diagnosis, I had a 3-year-old, a 6-year-old, and a 9-year-old. They're now 6, 9, and 12. We've talked about it. When I was first diagnosed, we sat them down and we talked about what cancer is. I didn't have any family history of cancer. They hadn't really been exposed to it. It was a new concept for them. So we talked about, like, what is a cancer cell? How does it happen? What are the treatments that people do for cancer? How does the medicine affect the cancer patient? What can you expect mom to look like on days that she's had her treatment? So we just left it at that initially. We knew my diagnosis was stage 4. We knew the terminal aspect of it. But we wanted to give them a little bit of time to be familiar with cancer just in and of itself before we introduced that. It was about the time that I joined my clinical trial, my second line of treatment, that we sat them down and had another conversation, like, you know, that mom has cancer, she's got this medicine, there's there's different stages of cancer, and that has to do like where the cancer is, how far it's spread in the body. And when it reaches a certain point, a lot of times the doctors don't necessarily know how to get rid of all of it. And so it's going to keep growing, and you may have medicine for a while that will work, but then it may stop working. And so you move to another medicine, and eventually we might run out of medicines that would work. And so that's a possibility that I will die from cancer. So that is something we've talked about with my kids. It's a big concept. And like Camilla, I've been really fortunate to be active and overall really healthy. And they don't go with me to the hospital. I don't wear a 24-hour pump with this treatment that I'm on, so they don't see that. They don't see a lot of my cancer journey. They just see mom. And some days she goes to Houston, and then she comes back, and she's tired a little bit and doesn't want to eat very much, but then she still takes them to soccer practice and takes them to school. So I don't think it's a concept that they hold all the time, but it's something that they do pick up, and then we have to kind of reprocess, especially with my youngest. It's something that we have to reprocess. I think that being honest with them is really important. And it's just this ongoing conversation that we're having.
Wow. Anyone in the audience want to share how they shared with their children, or do you have any questions? I'm not sure how many more minutes we have in terms of, because we have a question? Oh, can we?
I think also that it's really interesting that each kid responds differently. So even though your kids are close together, they may have completely different responses. When I got diagnosed, I had a 25, 18, 17, 14. And my 14-year-old, who had been my little attached at the hip kid, said, "I'm sorry, Mommy, I know you're sick, I just can't see you." So for 2 years, we'd have dinner together, she'd go to her room. I'd pick her up from school, she'd go up the stairs, and on the way back, she'd yell, "I love you, Mommy." But she couldn't process, she couldn't handle seeing me sick. So I lost my kid for a couple years. And then once I started healing and looking like Mom again, so I lost all my hair, my lashes. I'm normally dark-skinned and I was very pale. Once I started looking like Mom again, I got her back. But that's why I'm so thankful for the young woman that was speaking today about kids talking to kids. Even though I said, we need to get to therapy, you need to process this. My other kids were definitely like attached to me. My adult children moved back home during treatment. But every kid responds differently, and even though it's so painful, you gotta let them do their thing and help them along.
Thank you. I think Lauren's presentation was not aired live brought up a really good point. When adult patients come to see me, I ask about family history, and then I do ask about kids because you want to, if you talking about genetics and things, but I don't actually ask about how are they coping with your parents having stomach cancer, and something that's really missing, and I think Lauren took it upon herself to really try to fill a gap, because when she was a child of she is a child of a stomach cancer parent, she didn't have a place to go. And so I think with her network or high school, I think maybe this will be something that could be very helpful to teenagers especially. It sounded like, there is a great need for teenagers. When you're too young, you may not understand 100%. But when you're in that age struggling already with other issues, and then your mom gets sick maybe, or dad gets sick, it's more difficult to process. So I think there's things happening. Advocacy groups like this can support that, and parents as well. Anyone else with any comments? There's a couple comments over there.
It's me again. I'm not gonna lie, that's the part that I came here for. I have a huge struggle. I have 2 children. My namesake, Jamal Jr., he actually plays on my defensive line in football, and we're super close, but we don't talk a lot about this. The time in between him asking me, "Hey, Dad, are you all right?" is getting closer and closer, so I can tell he deals with it a lot. Before this whole cancer thing happened, I was probably a good year and a half removed from a 14-year marriage to where I ended up with the children. And I got to know my kids as like a better relationship plan, almost like both roles before I was always working and things like that. So I wasn't around them a lot. And then we have my daughter, Jasmine, who turns 12 in a couple weeks, but she found out a lot about herself. I got both the kids into therapy before cancer, just with the split and everything. And Jasmine is diagnosed with a panic disorder, a severe panic disorder. Without any of the cancer around, anything like that, it could be just me having the flu or COVID, and it will put her into a delirious state sometimes. Like, "Dad, make sure you're saying your prayers, make sure you're saved. I want to see you in heaven. We're all gonna die," like hysteria. And she's worked hard over this last year or so, and she's on medication, and she is blossomed and is amazing, beautiful soul, and that's all gone now. She worries a little bit about cancer, but I sugarcoat everything, especially as far as them two being in the line of fire with me having signet ring cell. I kind of mute that side out of things, but I know that that's what's coming up next. I need to communicate with them and let them know what's going on. The best thing that I do have is that the way that I've been able to handle everything, and they've watched that. So I know that they know at least that you can get through it. Outside of that, I don't know how to communicate with them about that. I don't have that tool. So any of you guys that have gone through it or are going through it, anything that you can give me or help me with that, I'd appreciate it.
Thank you for sharing. I'm sure there'll be a lot of emails going your way. I know that patients who have found this support group, actually, they're like, I sent out one email, and then I woke up the next morning and there was like 20 answers. And I was like, wow, can I do that? But they're like, no, doctor's not allowed. But we have our own networks, don't worry. Anyone else up there?
I'm going to apologize right now. My stomach is gurgling really bad. So if you hear it, it's my stomach.
That's all of us.
Yeah.
Most of us.
So I think I've mentioned before my twins, when I got diagnosed, they were 14 girls. They have had major medical issues since birth, so they have always been in counseling. And so I was very fortunate that when I did get diagnosed, I could get them into counseling immediately. Before I was even staged, both the twins went to see the counselor, and then the second daughter, who hadn't been going to counseling, I took her into counseling. She didn't know why, but I said, maybe you can talk about your feelings, and she looked at me dead square in the eyes and said, "You're sick, aren't you?" And I kept it for my kids because I didn't want to tell them anything until I got staged. It's kind of like, I'm sick. What are you sick with? I don't know. What stage are you? So they were old enough to know to ask those types of questions. So I didn't want to go to them with no answers. I wanted to be informative because for me, myself, I like a lot of information. Give me all the information that you have and let me digest and process, and then I can, go forward. My middle child was like that. She actually shut down to the point where she was breaking down at school. So, and again, I was fortunate enough to let the counselors know. So she took in a blanket, a stuffed animal, and a picture of me and her. And she was able to stash it in a little cubby. And when she ever felt like she was going to break down, she could just run into counseling and go into this room, shut the door. And she didn't have to say anything. She could just hold up a pass to the teacher. And the teacher knew, because they were all looped in with me being sick. She could just take off and go straight into counseling. Because the first couple of times she had the panic attacks, she would come home. I would go and pick her up and bring her home. And then I was like, I don't know if she's working the system or not. So we're going to have to change our plans. Let's see if we can get her to stay there. So she would basically decompress for a couple of hours. Well, not even a couple hours, maybe just an hour, and then she'd be ready to go back to her next class. So I felt the network of people that were in our corner helped my children get through a very emotional, difficult time. Because when I got staged initially at 1B, before my pathology report, the middle one ran to the computer and looked it up. Said, "Oh yeah, Mom, you got a great chance of survival." Yes, and she got really happy. But the minute my hair started to fall out, I found a new sense of caring for my kids, or them caring for me. Like, I would be in the bathtub, and they'd all three come in there and wash my hair, rub my back, wash my body, and they had never done that before. I was the one that always, it's called, my husband's Japanese, we call it bocha bocha, which is bath. And they would come in and go, "Mommy, you're doing bocha bocha, we're gonna give you a bath," and they'd, pamper me. And it was just for me, it was sad to see the roles reversed, because I was always the one giving them baths, and now they were giving me baths. And when my hair fell out really bad is when my youngest daughter, I was in the bathtub, and she was rinsing my hair with a Korean bucket. Cammy knows. I'm Korean American, by the way. There's a little bucket that we get, and you just pour it over your head. When that happened, my hair just flew down my body, and the entire surface of the water was black because I had long black hair. And she didn't cry. She goes, "Mom, it's okay. You're beautiful. You're beautiful." I had chunks of hair, literally, like the entire bathtub was black. And she took care of me, and I was crying. It's just hair, right? But at the time when you lose it the first time, like the second time, I was like, who cares? I shaved it off. I was like, warrior woman, whatever. But the first time it happened, it was devastating because, hair is a sense of identity and beauty.
It's recognizing yourself in the mirror.
Yeah.
Yeah.
Yeah, it's really hard. So she helped me out of the bath. At that point, I wasn't very stable on my feet because Flot was just so relentless and kicked my butt. She picked me up and helped me out of the tub, dressed me. Like I said, it was just a role reversal. And I cried, and she kept saying, "Mom, it's just hair." And I said, "I'm not crying about that anymore. I'm crying that you're taking care of me, and you're only 14.
Oh.
Why are you taking care? You shouldn't be taking care of your mama when you're 14. And she said, "But that's what I want to do." And I mean, all three of the younger ones had different responses to my cancer and my chemo. My oldest daughter was probably more understanding, and she was more stoic in the way that she was the oldest, so she had to, be the foundation for the other three, and she had to show that, Mom's going to kick cancer's ass, and it's going to be a wonderful joy to have her ring that 5-year bell. Unfortunately, I didn't get to ring that bell, but I'm still here after 5 years.
You've made it 5 years.
I did
You're
make it
2018.
I did. I made it 5 years, but I was expecting to make it 5 years NED, not 5 years stage 4. But, I'm at this point, I'll take any day that I can have with my children. So
Yeah.
that's my story. Thank
I
you.
think you touched upon a really good support that we didn't mention, and it is like the community of other parents. My daughter's soccer coach is an oncologist. So when I tell her, "I'm sorry, I can't bring Luna to practice today because I just had full fury," she's like, "Focus on your treatment, no problem." And there were so many parents that stepped up to the... Initially, I didn't tell anybody. When I was stage 1, I was like, I don't have a leg to stand on. I'm not going to tell anybody. But once I was stage 4 and I let the teachers know and I shared it with other parents at the school, they were offering, "You know what, you don't feel well? Let me watch your kids. Let me bring over a meal. Let me take, Liam to soccer. Well, do you need help with rides?" And so I was so lucky that I got such a warm and supportive reception. And I feel like if people were open enough to share that with the school community or your local community, your neighbors, it could offer another channel of support that might have not been there otherwise.
Yeah. So I told friends, and it's friends of friends, I have a friend who had cancer. Let me help connect you, and they have resources. And now I get to be on the other side of that with my friends who just got diagnosed. And that is a really good opportunity to find resources, especially we find a lot of resources online, but local resources, your local community, I think is important. Because of that, we were able to find counseling for my kids to be in. I told their teachers know, their school counselor knows, all of our friends' parents know, and like you said, that's been part of living with cancer for our family, is this community of support, the people who will take the kids to school when I just had treatment. And so local community is important for that.
I actually was a photographer for my children's soccer teams and lacrosse teams. So even though I was going through chemo and I had lost my hair, I wore hats. They were the ugliest things in the world, but I wore those ugly hats. and I wore a parka, and I had my gloves, and I had my telephoto lens and my unipod, and I took pictures all year long, and that saved me. It gave me purpose. It gave me a reason to get up and exercise so that I could have the stamina to be out there for an hour and a half, 2 hours. Unfortunately, I had 2 games back to back because I had the freshman, sophomore, my twins were on, my middle child was on varsity. So I was like, oh God, I can't do just one kid, I gotta do the other one. So I was there for hours, and I took pictures of all the kids. And then I found out all the parents found out I was sick, and they did a meal train where they brought me food, and it was just lovely to have that camaraderie and that community. But at the end of the season, they actually did a banner that said Team Tahara, which is my girls' last name, because it was hashtag Team Tahara then I was doing all my posts. So they did that. They presented me with flowers and a gift card and said, you know, we can't believe that you took our pictures. Some of the kids didn't know I was sick because I had a hat on. It's cold out there, so they just thought I just had this hat on because it was cold. And when they all found out I had cancer and I was going through chemo, they all came up to me and hugged me, kissed me, and cried. And it was just this big, huge, round kids just circling me crying. And I was like, we can't cry, we gotta be happy. And so there's a big picture of me with them, and I will never forget that night because it was unexpected. They came up to me and said, Mrs. Tahara, can you take a picture of us? And I said, sure, you know, because they're submitting most of these pictures for a lot of them for the yearbook. And then I turn around, and all of a sudden there's this banner, and even my girls were surprised. They didn't know what was going on. So it made them just love their teammates that much more. But community is huge. I don't think I would have made it through the last sessions of FLOT because it was so hard, but I knew I had to get up and take pictures. So I fought through it and got up and said, Cancer, you're not taking this away from me. I have to be present for my kids.
Thank you so much for sharing again. I think it takes a lot of bravery and courage. I see my patients, and there's some cultural, barriers, self-image barriers, and like a fear of losing control if you share, looking weak. There's a lot of things that I've heard patients say that I don't really want to share this yet. I don't want to share this just yet. And then maybe later. But I hope that people who are listening out there today with your courage, Rachel and Cami sharing, in the entire room, that perhaps if you can open up at whenever time it is appropriate for you to share your story, it may help someone else or their children and help build a community and get bigger. So we can do a lot more things like, one person, it's hard for one person to do something, but in an empowered community can do a lot more. So thank you so much for sharing your stories today. I think maybe we need to move on to our next session. I'm sure there's a lot of questions, so there's opportunities to talk to each other.
Okay, thank you.
Thank you.
Oh, am I speaking next? I feel like we could skip my talk because we already covered everything. Maybe it will be a continuation of our last session. I didn't really plan it to be this way, but maybe Aki planned it to be this way. So let me share. Okay. So for those of you, obviously, who are here, but maybe listening on, my name is Yanghee Wu. I am a gastric cancer surgeon at City of Hope, and I've been in practice for 12 years. And believe it or not, I almost 99% of my patients are gastroesophageal cancer patients, and I am a surgeon. And if you come and see me, I'm pretty tough. I'm not like this mushy crying person. So let me just tell you. So Aki and I were having a conversation about this symposium, and we thought that, perhaps one of the topics that is a little bit challenging to talk about and maybe something that's really important to bring up is talking about shared decision making. And I think from breakfast this morning to the patients sharing their stories, I think what we're talking about is shared decision making. How can a patient and the doctor communicate in a manner that is informed and communicative, and really work together as an entire team, not just you are the patient, I'm the doctor, but as a care team to be able to provide the necessary treatment and information to make informed decisions about the next steps. So these are some, these are my disclosures. I'm proud to be part of Hope for Stomach Cancer for a long time. So I think of us as a road less traveled, a gastric cancer surgeon, scientist in the United States. When I try to tell my mentors or my friends are like, oh, that's stupid, you're never gonna get a job. But here I am 12 years later. So I spent my time doing robotic gastrectomies, open, HIPEC, PIPEC, clinical trials, and study the peritoneum oncolytic virus in my lab. So the road less traveled is actually not alone. It's with patients as a doctor or surgeon. I have the privilege of meeting all of you and sometimes grieving for some. But we have those who are with us, and we're gonna move and do our best to make sure that we find a cure. And when I say cure, not just a treatment for today, for tomorrow, but for long-term survival, for benefits that address not just the cancer, but the complications of the cancer and the toxicities of the treatment and all the aftermaths that come when you're diagnosed with this disease. So there are many things that make up cancer care, but one thing to know is that you're not alone. You have this community and a lot of doctors and institutions and programs that really care about you and would want to take care of stomach cancer patients. So it's very complicated, right? Doctors will tell you, oncologists, GIs, it's very complicated. It's evidence-based. We need comprehensive stomach cancer care. Not that much of it exists in the United States, where we're trying to get there. Dr. Strickland and I were just talking about the importance of comprehensive cancer care for our stomach cancer patients. And then all day today, we were talking about the community of supporters. How do we get empowered? We need your family and friends, researchers, other patients who will help, doctors and nurses. And it should be patient-centered. This is all about the patient and their cancer. So I was trying to prepare for this talk, and I didn't know how to do it. So I've never given this kind of talk before. So I looked up online. I mean, like, how many choices in a day do we make? What decisions are made? You get up, do you brush your teeth? Do you not brush your teeth? Do you wash your hair? Do I drive? Do I leave now, or do I wait like 10 minutes until the traffic is gone? I mean, all these decisions, and there was some paper, it's based, this is not a number that I made up, so you can Google this now. It's actually a paper from Europe. Some scientists actually did a study to look to see how many decisions do you make in a day. 35,000 decisions, choices that you make consciously and unconsciously. But what happens when you get an unexpected diagnosis of stomach cancer, like Rachel shared and Cami shared? Everyone shared that nobody expected to have stomach cancer, or your child to have stomach cancer, or your mother or father. And then sometimes it may not be a one-time deal. You fight, and then sometimes it can come back. And I think stomach cancer is a diagnosis that once you have it, you may be NED, you may be cured, or you may be stage 4 and living with it, but it is part of your life. And during this whole process, wherever you enter, stage 1, 2, 3, 4, and some decisions are easy. Stage 1, NCCN guidelines, resection, ESD, and the benefits are very clear. You make an easy decision. Maybe for some it's not that easy, because some patients will say, well, I don't want my stomach out. You know, it's easy for a surgeon when patients come to you and say, I want my stomach out. I'm like, okay, if that's appropriate, we'll do that. Others say that I don't want my stomach out, even though it is clearly, very clearly curative. So decisions are not that easy to make because there are a lot of unknowns, because it involves understanding of your stomach cancer and the alternative choices that you may have. And who gives you that information? Google Doc? Sometimes before you come in, many of the patients have this Google Doc information. They've gone to 3 other oncologists, surgeons. So doctors, the internet contributes, your preconceptions of other patients who've been treated for that, your priorities, values, preferences, the treatment options you are offered. Some people offer this and others offer that. Which one is the best? And then harms and benefits. It's not just black and white, because there's a lot of gray areas and unknown. And I think that unknown is very unsettling. It's unsettling for me, but I don't know how I can't imagine how unsettling it must be for those. I'm not a big numbers person, so when people talk about statistics, they ask me, what's my prognosis? It's very hard to tell you a prognosis for one person, even though there are numbers from a textbook or per stage. And I can quote you all the data that's out there for clinical trial, the results of randomized controlled trials that had gone into NCCN. But I think that discussion about what those numbers mean to the individual patient, it has to be a communication between the doctor and the patient and the families. So there's so many things that go into shared decision making. And then you become information overloaded, right? So I read a article talking about, like, in a 60-minute conversation in a doctor's office, patients sit there and they're told about their diagnosis and all the treatment options. And then when they leave, they did a study, they asked the patients, like, so what do you remember about it? Maybe less than 10%. So I feel like I may say a lot in a meeting with my patients, and I learned this, but what you retain and take away may not be that much. So maybe sometimes we need to listen as well and really figure out what's going on. Because look, there's guidelines, and then there's 238 clinical trials actively recruiting in the United States for stomach cancer. There's over 7,000 peer-reviewed publications. And none of us know all of the information, but there is enough to help. So then we talk about risks and benefits. I was starting to fill out this risk and benefit thing, and it allows you to fill in like a little more for each side. If you fill in one more for risk, it balances out. I didn't know that. This is PowerPoint. But this can go on. There's so many risks, right? And there's so many benefits. Or are there? Benefits of treatment, the options of therapy. But I wanted to just put some things into perspective and maybe share this common theme that I've been hearing, that the stomach cancer journey is not a one-time thing. You don't come into the doctor, just get surgery, and then it's gone, because your stomach may be gone too. And even if you're cured, there's lots of aftermaths to deal with. So the complications of cancer is not the only thing that really needs to be discussed. Side effects of treatment also need to be discussed. And so it becomes very, very complicated. And then how do we have shared decision making? It's not that easy. There are expectations, what you expect from a surgeon and what a surgeon or a doctor expects from our patients. There are lots of uncertainties that need to be addressed. Can we do this in 15 minutes? I'm not sure. It's an ongoing conversation that we need to have. At a point when you become comfortable with the decisions that you have made, it may be easier for you to participate in your own care and feel comfortable with your decisions. Emotional stress or distress. I see this quite often. But as doctors, sometimes we don't know how to deal with it. Then we refer to we call in the social worker. Well, they come and go, and then the patient may still be in distress. So I think in groups like this, when I hear what is important to you, when doctors learn of the concerns that you have, and if you share them, maybe it will help with some of the decisions and the choices that are better for you than for others. The unanswered questions. I think you should write down your questions. So I learned something when I was a resident from a surgeon, Dr. Chabot, who's a pancreatic cancer surgeon in New York. One day, I was in clinic with him, I was just watching him, and a patient walked in. This patient had, those legal yellow notepads? He had 3 pages of them, and it wasn't even a printout, handwritten. Okay, and I was like, oh my gosh, I'm gonna be here forever. Well, we were there for quite some time. The consult was for like 30 minutes or something, and we may have been in there for 90 minutes. But Dr. Chabot never left the room, and he never even looked at his watch. And I said, if I'm gonna be a surgeon, that may be the surgeon I need to be like, because he really answered his questions, listened to the patient, and I thought maybe that's something that we need to do. Well, it turns out that that patient was a writer for the New York Times, and this was his, he was a patient, but that was the way he coped with, he had a lot of questions, maybe like Cammy. Well, Cammy didn't come in with 100 million questions, but I think everyone has questions that need to be addressed. Some only have one. They'll say, when is my date of surgery? Others have more. So, the unanswered questions I think should be answered. And then things that we don't know about, the financial burdens, the children that they need to take care of, their parents, or other things that may be affecting their things. So I put all these questions here because whatever the mixture of things that must go into this box, I think we need to create ourselves. For each of us. Maybe there's some formula, but I don't think all formulas work for everybody, and I don't like algorithms. And maybe if AI, Dr. Strickland, if AI could figure this out for us, it would be great. But I really believe that AI is based on data. So this is the data. We need to ask individuals what is important to ourselves. So I figured some things like identify your advocate, build your support network of family and friends. It seems like I'm preaching to the choir, because you've already done this if you're here, right? Create a trusting environment. Well, if you go someplace and you don't trust that it's the best thing to do, get a second and third opinion. I always encourage my patients, please go get a second opinion or find a clinical trial. Maybe if it's not here, we'll see if we can find somewhere else near home that may work for you. Establish your treatment plan and not just accept it as like, oh, this is the only choice that I have to do it or else. And really discuss what the alternatives are. What is the complication? Not just the risk of a complication, what really happens if that does something important to you. And then I always think about, since I became a cancer surgeon, life and living. Life and death versus living. And for a person who's living their life in their 20s, or 80s, this may, without any health problems or cancer, this may not occur to them, but what I realize is that life and death may be black and white, but living is like a spectrum of colors, and I don't say gray. There's sometimes it's fiery red, and you're having like this amazing, you have the future ahead of you, your job is going great, and then sometimes it's like, I don't know, what's black than black, like ugly pewter color. Like things are falling apart, you got into a car accident, you lost your job. But this is something like that, it's like part of the living that something drops, like a diagnosis of stomach cancer, and it's a spectrum of how you cope. And I think informed decision-making or shared decision-making in your journey during this process may help you make good choices about your cancer care. So I don't know what the formula is really for the optimum stomach cancer treatment outcome for everybody, but I think it's something that is developed with scientific knowledge, medical information, and your priorities and other things that are important to you. So I encourage all of you to be empowered and empower the stomach cancer community. We want to share the hope of life and living and the gift of time. This is something a patient of mine shared with me. He said, "Dr. Wu, thank you for the gift of time." And I didn't realize time is really, really precious. Every moment here today and for tomorrow. So thank you for your for listening, and I'm open to any questions, or if we have no time, we can move on. That's it. That was my last slide.
Next, Dr. Matthew Strickland will be speaking about biomarker testing in stomach cancer.
All right, hi everyone. I'm gonna get the slides loaded up. All right, it looks like it loaded up. Hopefully everyone can hear me okay. I want to say what a privilege it is to be here with everyone. I've started getting to know some folks. I'm sitting with them and speaking with them in between rooms here, and I'm looking forward to getting to know other folks in the room. So the title of my talk is Biomarker Testing in Stomach Cancer. What should I know? I practice at Massachusetts General Hospital. Here's a shot on the left. But I also wanted to include this photo on the right because what we're looking at is the Longfellow Bridge. And MGH is situated right here, but the bridge actually connects us to Cambridge. The reason I want to highlight that is there's an incredible pharmaceutical and biotech presence, as well as other renowned research institutions in Cambridge. And this bridge is emblematic of what I'm trying to do with my time. About half the time, I'm taking care of patients with gastric and esophagus cancers in the clinic. And the other half of my time, I'm focused on clinical trials, as well as what we call translational research, to try to use patient tissues to learn more from a scientific standpoint, to then build the next clinical trial. And before we continue, I wanted to pause for just a brief moment and talk about the importance of Veterans Day, as well as Remembrance Day. So I'm from Canada originally, even though I've since immigrated to the US. And in Commonwealth countries, most countries call this Remembrance Day, where we pay special homage to the veterans, as well as veterans that have been lost. I'm in part thinking about my grandfather. His name was John Jackson. He served in the Royal Canadian Air Force. And as mentioned, in Commonwealth countries, it's customary to wear a poppy today. So that's why you can see my poppy. The other reason I want to spend a brief moment on this is I see a lot of parallels between veterans and brave people like my grandfather, who had a call to action that he frankly didn't want to get. I see a parallel between those people and the people in this room and our patients. You know, I heard the word courage and bravery, and that just scratches the surface of what inspires me about our patients and the people in this room. So now shifting back to the talk, this is a brief overview. I want to go through what is a biomarker, how do biomarkers help patients, and what biomarkers are relevant for patients with stomach cancer. And then I'll touch a little bit on some visions for the future. So let's try to define a biological marker, which is a biomarker for short. I've actually adapted this from an FDA definition because I think it gets a little too complicated. I've defined it as a measurable characteristic that gives feedback on a normal or abnormal biological process alone or in response to a treatment or an intervention, something we've done for the patient. So it's pretty broad. Let's try to break it down a little bit further. This is a diagram of different categories for biomarkers. And as you can see, there's a lot of categories here. It can be safety alone. Some biomarkers are diagnostic. There can be susceptibility or risk biomarkers. The first one that comes to mind is well-known BRCA alteration. That is an inherited alteration for some people, and that can elevate risk for developing cancers. Some biomarkers are prognostic, so they provide information on how a patient's clinical trajectory might turn out. And then predictive biomarkers, which is something about the biology of a tumor that tells us what therapies or what interventions may or may not work. And there's a star next to predictive biomarker category because that's what most of my talk will be focused on. Lastly, sometimes there's biomarkers for how drugs will work in the body or just monitoring disease status. And so how do we bridge the gap between biomarkers and how they're actually going to help cancer patients? And I would say that biomarkers are tools to help us achieve what matters most to patients and their loved ones, living longer, living better. I think that's a fairly acceptable definition, but we do have some work to do because now we need to think about designing clinical trials that are actually going to move the needle for our patients. So how can we translate living longer, living better into some more measurable definitions? And this led me to design this slide, which is trying to provide insight on how oncologists think about living longer and living better. And so these are endpoints or clinical outcomes that I think everyone's familiar with. Overall survival, overall response rate, progression-free survival, and others. Overall survival is the gold standard. We want patients to live longer, and while they're doing that, we want them to have achieved a balance where they're living without symptoms and they're thriving. The problem with designing clinical trials with overall survival as the endpoint is they take a long time. And there's some measure of desperation. We have to get moving. We have to move these needles forward. And so not every trial can have overall survival as the primary endpoint. So what do? What's our workaround? Well, what we try to do is identify surrogate endpoints. And what that is to say is if we know that we design a trial with an experimental therapy and suddenly the overall response rate is much more impressive than what the current standard of care is, or alternatively, if progression-free survival is much more striking than what the standard of care is, that likely will portend a better overall survival, even though the clinical trial is not measuring overall survival a priori. And so I wanted to try to just quickly define some of the most important endpoints, and this will be relevant as we then shift back to biomarkers in stomach cancer. Overall survival is the average length of time patients are alive after the start of a treatment or an intervention. Progression-free survival is the average length of time after treatment in which a patient is alive and their cancer does not grow or spread. And overall response rate, this is the percentage of patients whose cancer shrinks or disappears after treatment. And just to shine a light on some of the nuance there, but it actually is quite important, the cancer needs to disappear or shrink to qualify as an overall response. But if we focused on disease control rate, suddenly we include cancers that are controlled, in other words, stable disease on a scan. And so these nuances are critically important as we design thoughtful trials, again, to move the needle forward. So now we're going to start to focus on some critical, or I should say really important biomarkers for stomach cancer. First, I'm going to focus on these three categories because they directly lead to decisions based on FDA-approved therapies. But there are many more biomarkers than what we're going to first cover. So PD-L1, HER2, and MMR. So let's take it one by one. So PD-L1 is a molecule that cancer cells express on the surface. And what happens is by expressing this protein on the surface of the cancer cell, it acts like an invisible cloak to the body's immune system. It turns out that our bodies actually have some decent, our immune systems have some decent ability to detect and attack and kill cancer cells. And it's only when that process is dysregulated and the cancer growth can overcome it that unfortunately leads to a cancer diagnosis. Cancer cells use this mechanism to evade that immune system's ability to attack, and they do that through PD-L1. And so this is a cartoon of this PD-L1 molecule being expressed on the cancer cell, which is pink, and interacting with its counterpart, which is PD-1. This is like a stop sign, and it tells the immune cell to calm down, turn activity down, do not attack. Now that's obviously good for the cancer cell, and it's very bad for the patient or for us trying to treat the cancer. Once we begun to understand this mechanism, this led to the clinical integration of immunotherapy. And what happens is, by treating with drugs, typically monoclonal antibodies, we can prevent that interaction. And so you see that I've moved the stop sign here, where now this interaction is no longer happening. That results in that dial on the immune cell being turned up again, and immune attack of the cancer cell is restored. This has led to a revolution in cancer therapy. I also want to point out that immunotherapy is a pretty broad treatment category. To be more specific, the example I'm using is called a checkpoint inhibitor, but I think for the purpose of this talk, it's okay to say immunotherapy. And so high PD-L1 score suggests immunotherapy will work better. So what does that mean exactly? Well, it just goes back to that level of expression on the cancer cell. And so it's really a fraction that the pathologist will utilize when they're looking at the surgical specimen or biopsy specimen under the microscope. And basically they'll look for a number of tumor cells in the denominator, and then they'll determine what number of tumor or immune cells are PD-L1 positive in the numerator. And this results in what we call a CPS score, or combined proportion score. And why is this important? We know that cancers that are relying on this mechanism typically have a high CPS score. And we can see from these data, I've adapted this from the last presentation was ASCO GI in 2023. We can see here that we're looking at a comparison between chemo and immunotherapy versus chemo alone. And this is a hazard ratio. And so what I want everyone to focus on is a line that's basically at 1. So if the data falls to the left, that means that the combination is better. If the data touches that middle line, it means that this combination probably is no better than chemo. So let me help try to visualize this better with some boxes. When we see that the CPS score is less than 1, the lines touch. However, when they're greater than 1, when the CPS is greater than 1, the combination of including immunotherapy looks superior. The same trend is borne out when we look at a score of 5 as the threshold. Less than 5, the lines touch. This combination is probably no better than chemotherapy alone. However, a CPS of 5 or greater, we're seeing a benefit for patients to include immunotherapy. And I won't belabor the point, but again, we see the same trend using a threshold of 10. And so generally speaking, a patient with stage 4 gastric cancer whose tumor has a PD-L1 score of 5 or greater should be offered immunotherapy in addition to chemotherapy. And so I hope I've given a clear example of how PD-L1 used as a biomarker directly influences our decision for what to offer a patient in this scenario. Another way of saying that is if the PD-L1 score of a tumor is really low and we do not offer immunotherapy for that patient, we hopefully are saving them unnecessary toxicity, and that's a good thing. Let's move on to a separate example. We're going to focus on a protein called HER2. So I want to focus on the left side first. This is a normal stomach cell, and we can see that this is a protein that again exists on the surface of the cell. It is a receptor for other molecules like growth factors. And in normal physiology, when cells are meant to grow, growth factors will bind at the surface, and the result is there will be a signaling cascade inside the cell that results in certain genes being turned on such that the cell grows when it was commanded to. Now, this is different in the case of a cancer cell. Cancer cells, by definition, want to grow, and they begin growing out of control. They no longer respect what the rules are that the rest of normal physiology is trying to govern. And one mechanism for this is overexpressing a protein like HER2, as you can see here. And this allows the cancer cell to basically grow and be viable based on little or none signals from the outside, and basically results in uncontrolled cell growth. Now, because we understand that biology, this led to developing a treatment that specifically attacks this vulnerability. And trastuzumab is one example of HER2-directed therapies. Again, this is an antibody, and by binding to the cell surface protein, it can shut this mechanism down. And so HER2-positive cancers are uniquely sensitive to shutting down HER2. And so this is another example of how, if the tumor is HER2 positive, it would definitely be recommended to incorporate HER2-directed therapy in addition to chemotherapy backbone. Let's move on to a different biomarker, and this is also directly relevant for approved therapies and conventional care. MMR stands for mismatch repair proteins, and I'm going to break that down. So mismatch repair proteins detect and repair mistakes in DNA. If you are alive and your cells are dividing, it's critically important that each new cell has a set of DNA blueprint instructions that are without mistakes in order to be a healthy cell. Now, nature has designed incredibly efficient mechanisms to make those copies faithful, but it's not perfect, just like anything. And so there's some low but constant error rate where small mistakes in DNA will pop up. And so that, I've basically depicted that by this is an inappropriate base pair shown in green that is not matching with its counterpart. And what happens is that, again, nature has given us the ability to detect this, excise it, which I've shown here, and then reintegrate the correct base pair. Everything I've described is normal, but it turns out that some cancers derive an advantage from getting rid of some of these proteins. And why is that? Well, the answer is mistakes piling up can be advantageous for cancer to derive a growth advantage. And so on the left, this is under normal circumstances, as mentioned. If a tumor has mismatch repair intact, which is akin to normal cells, there's not that many tumor-specific mutations, and that results in the immune system having a harder time detecting the cancer cell as something foreign. Now, on the other hand, when mismatch repair is defective, there are many more mutations that pile up. These are cancer-specific mutations, and in this setting, it's much easier for the immune system to say, that is a foreign threat, it is time to attack. And then again, when we give immunotherapy, we typically see a very high, exquisite response for tumors that are defective in mismatch repair proteins. And so current biomarker-driven therapy does look something like this. This example is for the first-line treatment. This is off of a clinical trial for patients with stage 4 disease. If PD-L1 is 5 or greater, patients should be offered a chemotherapy backbone with a checkpoint inhibitor. In this setting, we would not think about HER2-directed therapy. But by the same token, if HER2 is now positive, we should certainly integrate HER2-directed therapy. If tumors are deficient in mismatch repair, chemotherapy actually becomes a shared decision, in my opinion. A checkpoint inhibitor should definitely be part of the conversation with that patient, and there's really no role for a targeted therapy approach in this setting. There are certainly other biomarkers, and so I've somewhat broadly said, explore alternative approaches here. Examples of chemotherapy in our community, as everyone I think knows, is broadly a fluorouracil and platinum strategy. FOLFOX is one example of doing that, but it's not the only one. And then examples of specific immunotherapy and checkpoint inhibitor drugs, or nivolumab or pembrolizumab. And so I really want to emphasize that in the last 5 to 10 years, these biomarker-driven strategies have moved the needle for patients. And we saw data earlier from the BMS team that underscored this point. And so for all of these endpoints that truly matter to patients and their loved ones, biomarker-driven strategies are accomplishing our goal. This slide depicts some of the other biomarkers that are coming up on the horizon. EBV is one example. FGFR2 is getting a lot of buzz. In fact, there is an FDA-approved therapy for tumors that harbor this alteration. I'm going to talk about Claudin 18.2, which I think deserves specific attention today in a moment. And then there are other biomarkers such as NTRK, EGFR, MET, or even KRAS alterations that we can begin to go after. And these clinical trials are already up and running. So biomarker testing is crucial, but how often is testing happening? And so I want to show some data from work I've done. I partnered with a company called Prime. And what we did over the course of about a year was we reached out to community oncology practices. And it was basically a survey format, and we got to know their practice patterns and how often biomarker testing is actually happening at their site. The data we're looking at is from 3 separate sites across the US. On the left, we can see a breakdown of what is pretty much a standard treatment team. And on the right, we can, in the red box, I've shown the biomarkers we paid special attention to, but of course there are more. And we can see that the percentage of patients here whose tumors are being tested is somewhere between 55 and 65%. There is no way around this. This needs to be much closer to 100%. There's really no excuse that, that we're not getting closer to 100%. There are some logistical challenges. In fact, we did try to shine some light on why this number is lower than expected. Some of the answers came back outlining challenges such as long turnaround times for tests. And then sometimes the data in the state of the art is changing so quickly that a busy oncologist or a busy practice can't stay up to date on what the latest thing to do is for a given tumor and a given biomarker. And so we've got a lot of work to do. I think shining a light on the problem is one step, but we do need to streamline getting the biomarker testing completed and getting it reported in a timely manner. And if I had my wish list, I would want to hopefully educate patients that the first time they're meeting an oncologist, some of the, in my opinion, basic questions should be, what's the tumor's HER2 status, MMR, PD-L1? Now, certainly we could add more to the list, but that's a great starting point because each of those options have direct FDA-approved treatment options. And I had mentioned Claudin 18.2. This is a new target and biomarker on the scene, and approval for new therapy is expected soon, and I'm talking about in a matter of months. So this is getting a lot of buzz in our community. Briefly, if we think about cells that line the stomach, the highly acidic environment of the stomach requires a tight barrier. Those cells really need to stick together tightly, for lack of a better term. And the way they do that biologically is through proteins called tight junctions. Pretty good name, right? And so this is a normal scenario where we can see proteins that are called claudins that are tightly bound to each other. But what happens when the lining of the stomach develops cancer cells? One of the characteristics of cancer cells is they begin to detach, begin to float a little bit, and with enough time, they might even spread. And what results as those cells come apart is on the tumor cell only, there is more claudin that's exposed. And this actually has turned into a therapeutic target, okay? This means that we can now target these proteins to elicit a downstream immune response. And the example is zolbetuximab, which again is an antibody. There were 2 phase 3 randomized clinical trials that have read out in the last 12 months. And we know the patients are living longer, and it's taking longer for the cancer to come back for those that are destined to have a recurrence. And as mentioned before, those are clinically meaningful endpoints. So switching now to a little bit of the vision forward, this is some work that I'm doing at MGH. I believe that the tumor microenvironment will be the next frontier for biomarker discovery. So what am I showing you besides what are somewhat pretty pictures? These are stomach cancer tumors, and we're staining for different players that are on the battlefield, so to speak. So in cyan, we can see the tumor cells themselves, but in yellow, we start to appreciate the distribution for PD-L1, which we spent some time covering. We also get a sense of how immune cells are arranging themselves around the tumor cells. Red are CD8 positive T cells in this case. Magenta are macrophages. And we can begin to make some interesting observations by analyzing tumors this way. For example, we can see that the expression of PD-L1 is not uniform, right? We see it's heavily strong in this area, but in other areas, we don't really see it. The term for that is heterogeneity, and that can be a problem. Another example, and this is exciting in my opinion, this formation here is a structure that has been recently termed an immune hub. And we think that patients that are responding to treatment, namely immune-based treatments, that a marker of that is the formation of these immune hubs. And it's like immune cells coming together and priming for attack prior to then moving towards the tumor and executing that attack. And so we're actively studying right now if the identification of these immune hubs is a predictive or at least prognostic marker for our patients with stomach cancer. And then this is looking, a little bit more further in the future. But I want to make the point that even the sky is not the limit. So most people don't know this, but this is the International Space Station, and there's actually a lot of laboratory hardware on the International Space Station. And both NASA, as well as more and more citizen science, is happening. In particular, there has been significant cancer research done in the unique microgravity environment in low Earth orbit. And we're working on an application right now with my team to do translational research on the International Space Station with stomach cancer cells that are directly taken from patients. This is an early time to be advertising it, but my enthusiasm is boiling over a little bit. And so, this is somewhere that, one example of where we're trying to go to better serve our patients and uncover biology that we can use as a vulnerability to more effectively treat cancer. And even though this is a projection forward, I do want to make the point that 2 days ago, SpaceX launched a rocket, a resupply mission to the International Space Station, and we've been working with an implementation partner. The hardware that is on that rocket and is now being loaded onto the International Space Station is the same hardware that we will be using for our experiments using stomach cancer cells. So we do have a current tie to what's flying right now, and I think that's pretty exciting. So beginning to wind down a little bit, this slide is meant to summarize our program at MGH. It's led by Sam Klempner, who I think most folks know. Sam, he's absolutely wonderful. He's my primary mentor. He basically trained me to work through my training years, and I've been lucky to be hired and work next to him in the gastroesophageal clinic. We also work with other world-class people like John Mullen, who does a lot of our surgeries. And even though radiation has a slightly more limited role, Ted Hong is another world-class person that we work with and deliver radiation when it's the right thing to do for the patient. These pictures below, in addition to Sam training me academically with rigor in the clinic as well as the research lab, part of my training program was to go to his farm. And he taught me how to chainsaw. It was actually really hard work. So this is Sam's tractor. Yeah, exactly. So maybe you guys can talk to him. Yeah, exactly. And then the last photo I wanted to show you is this is myself skating with Ted Hong. So we have a great program. I'm really proud of it. And if our program can be of help to yourselves or loved ones, please just call. That's why I've left the number up here. And we're always happy to either see in person, talk to you over the phone, or sometimes we do remote second opinions. Sometimes patients can upload their documents, and we're going to do a thoughtful review. So we're always here for the community. This is my thank you slide. I did mention many of my mentors. I also want to say a special thank you to Aki. It's such a privilege to be here with this group, and I'm really happy that you invited me and I was able to speak. I'll take any questions. All right, maybe.
Can you go again with me for when you're talking about the claudin? So it's the increased acid that's breaking down the strands, or the cancer cells that are?
Well, you are bringing up an interesting question. I didn't comment on acid per se or a role for it, although there is some interesting research that suggests that's a mechanism for how a tumor cell will move out of its initial position. So I didn't comment on acid per se, but it's really, what I want to drive home is that the tight lining of the stomach cells is that integrity is lost as one of those cells becomes a cancer cell. And by doing that, more of this target is exposed on the surface of the cancer cell, in other words, the enemy. And that creates a therapeutic window where giving a therapy that hits claudin 18.2 will result in killing the cancer cells.
Thank you.
It's a low stress environment. Go ahead.
The new drug that you said is coming out soon, you showed a slide and
Yep.
you had stomach cancer cells. What about a person that had total gastrectomy and the effects of this drug on them?
So this is a great question. For a patient that has already had a gastrectomy, this is probably not a good option. So claudin 18.2 is not strictly, but it's highly specific for stomach cells. And so for a patient who's had their stomach removed, this is very unlikely to be a viable strategy. In fact, those trials, those patients were not included in the phase 3 trial that is going to lead to this approval coming down the pike. I will say, though, along that same thought, that some of the side effects to that new medicine called zolbetuximab is nausea, and which can lead to vomiting. And that's because this is a stomach-specific protein. And so that is one of the trade-offs, and that's something that needs to be managed aggressively.
Hi, I just wonder if quickly you could speak to second-line treatments and clarify if a patient doesn't have all the requisite biomarkers, but they're given second-line treatments for immunotherapy and targeted therapy, how and why does that work when it's added to chemotherapy?
Absolutely. Perhaps I could separate this into two answers, because I think the latter part of your question brings up an important point. You know, based on data thus far, it's going to be very difficult to drop chemotherapy in most cases. Now, as oncologists, we actually want to get to the point where we can do that because we're so confident in the precision therapy that we're giving. But the truth is, particularly when PD-L1 score is high and we can add immunotherapy or other examples, gastric cancer is so aggressive that there is this role for what we call the backbone, the chemotherapy backbone. And so for any line of therapy, usually chemotherapy will have a role, or it should be thought of. But then backing up, you know, biomarkers can be relevant at any treatment setting. And so if a patient has had biomarker-directed therapy in their first line, there's absolutely no reason that that same strategic approach can't continue in the second line or beyond. I will make the distinction again between some biomarkers have FDA-approved therapies, whereas others might be more experimental. And I'm just kind of speculating, but you could find yourself in the position where there might be a biomarker, but an oncologist might say something to the effect, well, I don't know that going after that biomarker is going to be better than what is the conventional second-line therapy. But I'm speaking a little bit general, but I think that at any stage, it's critically important to try to focus on the biomarkers at play.
I have a question here. Well, thanks for being here, first of all. A question related to surveillance. Can you just talk a bit about the advantages of including like ctDNA testing every 6 months, you know, on top of the traditional surveillance after like a full gastrectomy treatment and whatsoever? Like, what are the benefits in your point of view?
I'd be happy to. In fact, ctDNA is something we're very excited about and use frequently. I wanted to integrate it into the presentation, but I ran out of real estate. I think ctDNA is a perfect example of a biomarker for monitoring, right, in disease recurrence. I think that it is a critically important tool to be using. Now, if we look at the timing, right, it's really only in the last few years that the data is emerging such that the FDA has approved some of these tests. And we heard a lot about Signatera, which is a great example, and then there are other ones as well. The data has not, so the data is mature enough that these approvals have happened. It's not so mature that across different cancers, we know how it's meant to guide management. So even though I'm a big proponent for it, I'm acknowledging the criticism, which is that, and you might hear this more from the insurance side of things, right? That having the knowledge of a positive or negative result might not influence, it's not clear how that's going to influence the decision for what to do. I would say that the data is more mature in the colorectal space. We will get there in the gastric space. In fact, Sam Klempner and myself, we work closely with some of these companies on a couple projects looking at this. So I guess the take home is that I'm a big supporter. I think we need to be using it very frequently, and we need to tease apart things like how often should it be looked at. And then most importantly, if we see a negative convert to a positive result, what do we do at that point? You know, and the low-hanging fruit answer is, well, let's get a sooner surveillance imaging study. But beyond that, you know, do we start therapy? What does that therapy look like? These are unanswered questions.
I just wanted to know what your policy was on treating positive ctDNA patients without corroborating imaging tests. Do you treat or do you wait? I can tell you what happened to me, but I'm just curious about what was told to me was we don't treat ctDNA until we have visual or imaging tests that corroborate you're positive. So that's why I ended up sitting and waiting 5 months. So I'm just wondering if that's changed since early last year. Thank you.
This is a great question, and that's why we need the research designs to specifically address this question. I think the short answer and a bit of the blanket answer is no. We just don't have the data that a conversion to ctDNA positive status without radiographic recurrence, that we're going to gain anything by treating at that point. But I acknowledge the other side of this, and that's why I think we need to learn more about how to deal with this scenario, because to wait 5 months.
I think my thought process is if you were to treat it at a microscopic, manageable, low levels of ctDNA, could that prevent or have an effect on the recurrence that is, like 99% going to happen? Like, would it make a difference? I'm sure there's probably no data to suggest otherwise, but I think just, going down a wormhole and thinking, like, had I had treatment when I had the positive ctDNA test, would that have offset my peritoneal metastasis that was discovered, 5 months later?
I think biologically there's a chance that may have been the case. Unfortunately, the flip side is true. There's a chance that treatment wouldn't have helped, and we don't know what that proportion is, and that's what makes this scenario painful. Let me give you a quick example of a trial, phase 2, that we have at MGH. This is for colorectal cancer patients. They've been diagnosed, they have had their surgery, and the treatment paradigm there is adjuvant chemotherapy. After they're done that therapy, they then go on to ctDNA monitoring. For those that convert to positive, they are randomized into a treatment arm. And so treatment at that point is stepped up, and it's a more aggressive chemotherapy regimen than what they got before. And so that design is, I think, a really important design that is beginning to shine light on this question. I think we need a similar trial for our gastric cancer patients, and I should get to work on that. Okay, I think that's it for my time, but thank you so much, guys.
We're going to take a 5-minute break. You're more than welcome to get some coffee and some cookies or some peanuts outside, and then we'll resume in about 5 minutes.
Thank you, everyone. We're going to get going with our next speaker. And our next speaker is Dr. Yanghee Castillo, who is a medical oncologist and therapeutics researcher from City of Hope. And she's going to present on clinical trials and biomarker-directed systemic therapy for stomach cancer.
Thank you.
Thank you.
Hello, everyone. First, I want to thank the organizers to give me this opportunity to talk about the very important topic. So I believe today Dr. Strickland already covered a lot of my information, but it worth to repeat and you can enhance your knowledge. So often in my office, patients come for second opinion, third opinion. So they said, Dr. A, Dr. B, Dr. C mentioned something to me, what should I do? I said it's worth to have a discussion, but at the end, you are the driver of this bus. So we talk about the shell decision, we talk about informed decision. So it's worth to know what's going on in the world in terms of stomach gastric cancer treatment. So the topic of my talk is the clinical trials in biomarker-directed systemic therapy for stomach cancer. Thanks for the introduction. So my name is Yanghee Castillo. I'm from the GI group in City of Hope. So sometimes patients come to me and she said, what can you do for me? But don't talk about chemotherapy. So when we come to this beautiful Redondo Beach, everyone will talk about King Harbor, right? But you may ask anything else you can recommend. So we can talk about anything as long as it's not chemotherapy. But you can see a lot of beautiful things here. You can see the park, you can see the veteran beach, and a lot of other things we can do and see in Redondo Beach. Some, same goes for gastric cancer treatment. So based on the Cancer Genome Atlas project recently, I think it was from 2017, uncovered the 4 molecular subtypes of gastric cancer, so including CIN, which is a chromosome instability, GS type, genomically stable type, and also MSI. Dr. Strickland mentioned microsatellite instability, and also EBV, which is virus-driven. So we can see this is very heterogeneous disease, which can also explain why sometimes patient has excellent response, even with the first-line treatment, but sometimes patient unfortunately becomes very resistant. So the current approach to gastric cancer treatment, and then we also mentioned biomarker-driven, and then you can see on the left side, the pie showed us our scientists made a very good job, and you see there is a lot of biomarkers has been identified, including HER2, MSI high, and the PD-L1, and then we also will cover a little bit about Claudin 18, FGFR2, and also we have some other ongoing markers. So you can see the HER2 positive gastric cancer, so about 15 to 20% of the gastric cancer or GE junction patients, they have overexpression of this marker, so which definitely improve the patient's outcome. And I do see stage 4 HER2 positive gastric cancer patients came with large ascites, and then after a couple of cycles, everything disappeared. It's really a joy for a clinician when you tell patients what's the restaging CAT scan shows. So the other one is MSI high. So about 3 to 5% of the gastric cancer patients, they have this SI high, and then they have a higher response rate to immunotherapy. And then the other one, we talk about the PD-L1, And then lower, you can see the investigational biomarkers and the Claudin 18.2. So around 30 to 35% of patients, they will have this Claudin 18.2 expression. So we use the immunochemistry staining. So sometimes you may see in the paper, IHC 3+, 2+, and then also FGFR2. So, 30% of the patients, they have this IHC 3+, and this is served as a response predictor for, using FGFR2 antibody. So we can talk a little bit later in the FIGHT trial. And then also we know there are 7% of the gastric cancer patient may have FGFR amplification, and again, they predict the response. And then also now in City of Hope, I believe in Boston, we also have a lot of trials ongoing. So one of the biomarker, which is Caprin-1, and then we are opening a trial as well as phase 2. So basically this marker expressed only in cancer cells, but not in the normal cells, which, provide more options. So on the right side, you can see the beautiful anatomy of the gastric body. And then we mentioned about different subtypes, and then we can go first with the Claudin 18.2. So I spent a couple of years in the lab studying Claudin 18, actually in lung cancer. So that was Claudin 18.1. So Claudin family makes up the tight junction through the body. So you can see from here, this is a membrane of the cells, and this is a transmembrane domain. So you can see these beautiful green lines. This is a Claudin 18.2 in the gastric body. This molecular basically contribute to the cell proliferation and differentiation and the migration of the tumor cells. I think one of the audience mentioned about the acid. This is tight junction, right? When you lost this molecule, so the cells get broken and then also more permeable to some of the toxins. But for this overexpression is promote, the cells will lose the homeostasis, and then they promote tumor stem cells and then more like uncontrolled proliferation. So the presence of the Claudin 18 positivity is reported to be like 30 to 35% in GE junction gastric cancer patients. And then also based on the literature review, associated with the diffuse type. But in addition to diffuse gastric cancer, Claudin 18.2 expression is also frequently detected in the intestinal gastric cancer. We see more in esophageal cancer as well. So luckily, we have a drug which can, targeting this molecular, this overexpression gastric cancer. So zolbetuximab, we have ongoing couple of trials which have been presented in the recent years. So the mechanism of zolbetuximab is, this monoclonal antibody target and bind to Claudin 18.2. And it mediates tumor death through the antibody-dependent cellular cytotoxic, and we also call complement-dependent cytotoxicities. So preclinical study have shown that synergic between, when we combine this antibody to the chemotherapy, and then we find, more efficacy in terms of the response. So one of the phase 2 trial, the name is the FAST, which is using zolbetuximab combined with chemotherapy targeting Claudin 18.2. So for people who may not, familiar with those kind of Kaplan-Meier curve, so I will just show you. So you see the blue line, which is chemo plus the antibody, and the red line is just the chemo. So you see very nicely, even after a couple months, the two lines separated, and you can see there is difference. So we talk about Claudin 18.2, IHC3, plus usually in the literature, they use like cutoff at 70%. So that's why sometimes when patients come to me for clinical trials, so we have to do screening test because you have to make sure the expression level is enough for the drug to target. And you can see the lower graph, and then when the Claudin 18 expression is relatively low, and the efficacy was not that great as the first graph. So this FAST study showed that in those tumor overexpression Claudin 18.2, there is a survival benefit. So when we talk about survival benefit, usually we talk about overall survival. Sometimes we talk about progression-free survival, but in the adjuvant setting, which is after the surgery, so everything we gave after the surgery, we call as adjuvant. So in the adjuvant setting, we want to see whether there is overall survival benefit. So there are also two randomized phase 3 studies, which is a GLOW study, and then also there is a Spotlight. All the trials have very cute name. So they met the primary endpoint. And also similar reduction in the risk of death, because when we do clinical trial, first we want to know whether it's first we want to know whether it's safe. And the second, we want to know whether it's working. And third, we want to know it's better. And then the last one will be whether it will stay in the market. Similar reduction in terms the risk of the death and the survival benefit for, like we mentioned about progression-free survival and the overall survival. So pretty much using this drug, and we see the studies, they have very consistent data. So this is the representative Kaplan-Meier curve and showed from the Spotlight trial. So in this trial, the PFS, which is a progression-free, and also overall survival curves, started to separate, after 6 to 9 months. And this finding implied that maybe 20% of patients may not, get the benefit before they pass away. So tailoring the treatment to individual characteristics like genome, makeup, and the specific biomarkers will allow more effective therapeutic interventions. So Claudin 18.2 can be targeted by very different compounds. So we talk about drug antibody conjugate, we talk about different molecules, and also now we are using cell therapy, which is a CAR T cell therapy. So the FDA has recently granted clearance for use one of the anti-Claudin 18 chimeric antigen receptor T cells. So the name is CT041. And then in patients who had a Claudin 18.2 overexpression, including gastric cancer, GE junction, and also pancreatic cancer patients. So their phase 1 study published in 2019, which demonstrated a total objective response rate about 33% in a small amount of patients, because it's a phase 1, and so usually the cell numbers are small. And also in their phase 1b to 2, which is an open-label, multi-center clinical trial, which we also have on site. So we have a couple of patients screened for, and we're waiting for leukapheresis, and then I can share some of the data from the phase 1. And you can see from, so they had a paper published, and you can see the water flow. So this is a 0. So anything below 0, that means the cancer gets shrinking, and then the size decrease. So for any patients who enroll for clinical trial, you need to have a measurable disease. So that's how clinicians decide whether this drug is working. And then also this is one of the representative pictures, and you can see from along the time, the lesion, so which is invaded by the tumor. So you can see very nicely recovery from after the CAR T cell infusion. So the patients with gastric cancer, majority in this study, I think 80% of the patients are gastric cancer patients, and they have an overall response rate, duration, reach like 57.1% and then 75%. And then the 6 months overall survival was around 81.2%. So the next one, I'm going to cover a little bit about FGFR. So FGFR, when we have friends who have a cholangio, adenocarcinoma, so we know the FGFR is also very important because you can have a marker, that means you have more options. So many years ago, when patient has stage 4 lung cancer, so we think it's a dismal disease, but nowadays, stage 4 lung cancer with EGFR driver mutation, they live like a type 2 diabetes with insulin. So I have personal family, members, and then they have stage 4 lung cancer, they have, mutations, and then now we have a lot of medications, they live with the disease. And also I have a very close friend who has metastatic HER2 positive breast cancer and then has been 5 years and she plays tennis every week. So that means, the more biomarkers could be identified from the lab and, more options our patients can have. So there are also different aberrations in the FGFR receptor family. And in terms of gastric cancer, the most common is FGFR2 aberrations. So usually they're thyroid kinase inhibitors, so we may know that chronic myeloid leukemia, so it's really totally changed. My mother-in-law has CML. She has had this, TKI for CML for 10 years. So we talk about 30 years ago, CML is also not a very good diagnosis and the patient need to go through transplant. But nowadays with the TKI, so our patients have, normal overall survival, they have a decent, quality of life. So usually TKIs, they don't perform well in this setting, but again, we have antibody available, which is the bemarituzumab. So FGFR2, this is the antibody targeting FGFR2 and with the name bemarituzumab. You can see from this kind of like complex picture, but the main message I want to deliver is this drug was designed to recruit a tumor killing NK cells into the tumor microenvironment. So one of the FGFR2 fight trial, so which is a phase 2, and then this data has been published. They did not meet their primary endpoint, which is a primary progression-free survival. But we can see this trial selected patients with the FGF2B overexpression, or the patient has FGFR2 gene implications. But when we look at the survival benefit, so we find that this study showed that the addition of bemarituzumab to standard chemotherapy resulting promising clinical efficacy in the particular patient's population with FGFR2B overexpression, regardless whether it's gene amplification, so they use IHC 3+ or 30% above, suggesting that selection patients for the future using this drug will provide, we need more trials to identify whether, they can be standard treatment or, now I think there is more studies, even we have phase 1 as a front line when we identify patients with this overexpression. So the next one is about the HER2. So about like 20% of advanced gastric cancer patients will have HER2 overexpression. I think a HER2-directed treatment has significantly improved our breast cancer patients' life and also quality of life and life expectancy. As I mentioned, so I remember 2 years ago at the ASCO, when the author presented their Destiny, I think 3 breast cancer, all the audience stood up, they clapping for 5 minutes. This is really practice changing and also, improve a lot of people's life. So trastuzumab has been a standard care in the first line setting in HER2 positive adenocarcinoma. So even on the NCCN, so I like to share the NCCN guideline with the patients when they first come to our practice. So we can see the Kaplan-Meier curve. You see very nicely 2 lines separated. So, and then also the other thing I want to mention is like, if you don't send for the biomarker and then you don't know whether your patients will carry some very unique mutations, and then how can you treat them? So that's why as clinicians, we need to test the tumor cells. Like Dr. Strickland mentioned, like at least MSI and then PD-L1, and also we need to test the HER2 as well. So along the years, clinicians are sending more samples for the HER2 testing, but still you see even in the recent years, there are also 10 to 20% patients still did not get HER2 testing. So if we don't test the tumor cells for HER2, we will not be able to treat our patient properly. And then also, if we don't target the treatment, so that will not change the prognosis. And then also, there is a very interesting phenomenon when I was a fellow, so I look at the patients who have been treated for HER2-positive breast cancer. We find like around 20% of patients, they will lose their biomarker down the road. So now the next question is why? What happened? So we can see a very interesting phenomenon here. So the HER2-positive tumor, when you give them anti-HER2 treatment, then they become smarter. So they can have those kind of heterodimerization, so they combine to the HER3 receptor. So regardless, you treat the HER2, but still the cancer is growing. Why? Because they need another drug to target the HER3. So now we have some clinical trials ongoing to target the HER2 overexpression tumors as well. So pertuzumab, so for breast cancer, nowadays we use trastuzumab plus pertuzumab for the high-risk HER2-positive breast cancer. So this adding another drug to the HER2-positive gastric cancer has not been proven is beneficial in the metastatic setting or advanced stage of gastric cancer. So now clinicians and a lot of scientists are trying to see whether in the adjuvant setting, which is a curative setting, whether if we perioperative add anti-HER2 treatment, will change the patient's prognosis. Because sometimes even this locally advanced G-junction HER2-positive cancer, so we do perioperative FLOT. I believe many of you are familiar with the FLOT. So after FLOT, patient went through a lot. They had the surgery, they went through all the complications. After maybe 1 year, they come back to us, and then they find liver mets. So there is another question ongoing, whether, in the perioperative setting, whether we should add anti-HER2 treatment. Hopefully, in the next couple of years, we will have an answer. So I mentioned about drug resistant, and also the cells become resistant. So you can see from the pictures, and then HER2 targeting revisited. So HER2 positive tumors, they are very heterogeneous. So they can be, their primary tumor does not have a HER2, but when they become metastatic lesions, they can carry their HER2 overexpression. On the other side, after HER2-directed treatment, they can have also acquired genome alterations. So they can lose their HER2. So that's why sometimes when patients progress after anti-HER2 treatment, we want them to get another biopsy because we want to make sure the HER2 is still overexpressed. So we talk about the DDX1, which is a trastuzumab-deruxtecan, which is a very powerful drug. I personally describe this drug as a missile. So this is an antibody drug conjugate. They have a payload. So when this medication went to the cells, it becomes sliced. And then they release the drug, which can also easily diffuse to the other labors. And on the other side, So they can target the positive HER2 positive cells, but on the other side, the low expression HER2 cells can be also affected. So treatment with trastuzumab deruxtecan, which has been approved by FDA, that has been recognized as a second-line treatment for our metastatic gastric cancer or advanced unresectable gastric cancer patients. And this drug has significant improvement in response and overall survival compared to standard cytotoxic chemotherapy. And then, but also every medication has side effects. So notable myosuppression, and then maybe like I think 8 to 13% in the other studies, they find there are some lung toxicities. So the next drug, I'm going to spend a little bit of time about this phase 2 study, which is a TRACK 950, combined with standard treatment, which is ramucirumab and paclitaxel. So this molecule is also very interesting. The caprin-1, this molecule is only expressed on the cancer cells, not the normal cells. So make this target treatment more safer. And also you can see this is the objective response using the CAT scan. This is a regional tumor, and after 152 days, this is a tumor size. Although this is just individual pictures, but it shows there is something is working, and then we need more study, and then to show whether, in the larger sample, it's a significant improve the patient's outcome. So the next one will be tumor microenvironment. We all agree that in the future, tumor microenvironment plays a very important role. So far, there is a lot of stuff ongoing, but it's still in the lab. This very colorful picture shows you, like, as individuals, we are living in this society. We need a lot of friends, we need neighbors, and then when you target the tumor cells, if you just target the tumor cells, sometimes it's not enough because they have a very complex microenvironment. So the next question is, how are we going to target the microenvironment of the tumor cells? So many cells are involved, like, there is inflammatory cells, there is a fibroblast, there is vascular endothelial cells, and these stromal cells contribute to cancer growth. And we sometimes call as a niche, N-I-C-H-E. So the cells are very grounded by their neighbors. And then some of the cancer-associated fibroblasts, and you can see this complex cell types, and they release a lot of cytokines to the circulation and then make the cancer treatment more resistant. So microblast, which can be tumor-initiating cancer-associated fibroblast, they can be also tumor-promoting cancer cells. So as a second-line treatment for the gastric cancer, metastatic gastric cancer, so ramucirumab and paclitaxel. And we know that ramucirumab targeting the angiogenesis, and then in the Rainbow trial, which was a couple of years ago, but still very meaningful for our standard practice. And then I think the overall response rate was around 50%. So in the second line, and then if patient has no contraindication, we will go for ramucirumab and paclitaxel. And besides ramucirumab, we know that regorafenib, the very similar mechanism of the drug, was used in the rectal cancer setting, but now in gastric cancer, there is ongoing studies, and then there is a phase 3 study using regorafenib versus the placebo in the refractory advanced gastric or GE junction adenocarcinoma. So more study coming, and more results will be available in the next couple years. So understanding the precision medicine of the tumor environment is very critical. There is a limitation currently, in the mouse model, because we were unable to make very invasive or metastatic gastric cancer model. But the generation of these invasive gastric cancer models will provide a lot of, ongoing tumor microenvironment studies, and then we should, we don't lose our, we should keep on going. The other thing is targeting the pro-tumor genetic stroma, which is the microenvironment, and activating those kind of anti-tumorgenic microenvironment could be very promising, using which can also guide us to give more target treatment in the future. So take-home message. Several new drugs, targeted treatments available for gastric cancer based on the characterization of the cancer cells and the biomarkers and the tumor microenvironment. But to cure this type of cancer, we need effective combination of therapies. And clinical trials represent a fulcrum for oncology drug discovery and the development to bring safer and effective medicine to our patients in a timely manner. So shifting from the traditionally, we talk about chemotherapy, now we talk about more precision medicine, more biomarker-driven evaluation, molecular biomarkers, and also immune therapies. To cure this type of cancer, we need to understand more about the tumor and then also the tumor microenvironment, and then explore potential therapies. So at the end, I want to emphasize that informed decision-making involved a careful consideration of potential benefits and risk in terms of clinical trial. Patients always come to us, and then they haven't exhausted their standard treatment. They just failed their first-line treatment. They want to enroll our phase 1 study. So I will be very honest with the patients. What does phase 1 study means to you? And then also patients need to know, how the study will impact their treatment plans and also their quality of life and also their life expectancy. At the end, patients' well-being is the top priority. And then, they have the right to withdraw from the study anytime. And the efforts to cure cancer should begin with patients in mind. Thank you.
Thank you so much, Dr. Castillo. I know in the interest of time, we're probably going to save the questions for maybe after all the speakers.
Okay.
Or if you have individual questions you might want to ask her, they can come and meet with you or
Sure.
speak to you.
Yeah.
Thank you so
I
much.
can provide also my email. Feel free to send me emails.
Thank you so much. Our next speaker is Dr. Varun Bansal. He is a research associate in surgical oncology from Yale School of Medicine, and he will speak about management of peritoneal metastasis. Thank you for being here.
Right, good evening, everyone. My name is Varun Bansal. I am a research associate in the Division of Surgical Oncology at the Yale School of Medicine and affiliated with the Yale Cancer Center. It is a true privilege to be here today amidst a distinguished line of speakers, and I would like to thank Aki and the rest of the team for extending the invitation here. Over the next 20 minutes, I will try to summarize some of our efforts stemming from a nationwide initiative to delineate guidelines for the management of peritoneal metastases. And I must also admit, it is great to enjoy some pleasant weather over here as compared to where I come from in New Haven, in Connecticut, where it is pretty chilly right now. So, talking just a little bit about the Yale Cancer Center, we are the only NCI-designated comprehensive cancer center in the state of Connecticut, and one of only 2 member institutions of the National Comprehensive Cancer Network in the New England region. And this is perhaps the best picture I could find of my mentor, Dr. Kiran Turaga, who is the Division Chief of Surgical Oncology at Yale. He brings with him a wealth of experience in the management of peritoneal metastases, being an expert in HIPEC surgery. And we are very grateful for his mentorship in this initiative. And before jumping into further details, I would just like to give a little background about the peritoneum and peritoneal metastases. So the peritoneum, it is a thin, flimsy layer which lines the surface of the abdominal cavity. And metastases to the peritoneum usually represent an advanced stage of disease and can develop from various primary cancers along the gastrointestinal tract. And this could be the stomach, the small bowel, the appendix, or the large bowel. And just talking a little more specifically about stomach cancer, peritoneal metastases the peritoneum is in fact the most common site of metastases from stomach cancer. The risk is particularly higher in certain aggressive cancers, especially larger tumors, which can invade the surface of the stomach. And again, it represents an advanced stage of disease with often portending a guarded prognosis, even with the standard of care systemic therapies. And this is where we dive into the concept of regional therapies in order to address this aggressive disease process. And regional therapeutics for stomach cancer and in general for peritoneal surface malignancies, they primarily comprise of cytoreductive surgery and intraperitoneal chemotherapy. So the first part, which is cytoreductive surgery, it represents the resection of all tumor tissue which might exist within the abdominal cavity in the maximal extent possible. So this would involve the resection of the malignant neoplasm within the stomach itself, as well as all involved peritoneal surfaces. And the aim with cytoreductive surgery is to remove all macroscopic disease that exists within the abdominal cavity to the maximum extent that is possible. Now, in order to target any residual disease or microscopic peritoneal disease that is left behind is where we come into the second component, which is intraperitoneal chemotherapy. And over here, we can see a depiction of what the system looks like. So basically, what we do is we set up the chemotherapeutic agent within an infusion machine, and this chemotherapy would ultimately be administered within the abdominal cavity, just within the belly, and circulated for a period of either 60 minutes or 90 minutes after the major resections have been performed within the operating room. And when this chemotherapeutic agent is heated to a certain extent and circulated, it is known as hyperthermic or heated intraperitoneal chemotherapy, known more commonly as HIPEC, although it can also be circulated at room temperature or a normothermic temperature. So while there is a growing interest in the use of regional therapies for peritoneal metastases, formal guidelines are lacking at this time. And because of this, there are significant variations in the way that CRS and HIPEC are performed, not only across the country, but across the world. And this really brings us down to the purpose of our consortium effort, which is to streamline the way that regional therapeutics are administered not only for peritoneal metastases from gastric cancer, but from various other sites, so for peritoneal surface malignancies in general. Before delving into specifics, I would really like to address the big question as to why do we need a consortium? So this is a group of experts across disciplines which who come together in order to try and delineate best practices and agree upon standards by which any practice, in this case, regional therapeutics, would be administered. And it was, of course, not complete without advocacy efforts, and this is perhaps the biggest reason why we reached out to the Hope for Stomach Cancer group in order to promote this work and really understand how to conceptualize the current body of work within the patient's perspectives. As we are able to consolidate these opinions and perspectives from a multitude of stakeholders, we are eventually able to delineate standards of care, which we hope would be abided by or at least followed to some extent, so that all of us, we can speak a common language in the way that we administer this care. And once we have established these standards, we hope that this would eventually, especially with all the collaborative efforts that go into this process, would help us establish a platform to perform innovative research and clinical trials, which can help push the field further and reshape our understanding and advance our knowledge in this field, which will again tie into guidelines and further push and improve our understanding of standards. And lastly, while all of this work is going on, we need to remember that at the same time, we need to educate the future generation of physicians and surgeons, which would include, for example, me as a trainee going into residency soon, as well as residents in surgery, medical oncology, palliative care, and across disciplines, because the next generation of physicians are really the ones who will continue to pave the field forwards in the future. So with regards to the consortium itself, we are trying to build on our prior work, which resulted in the Chicago Consensus Guidelines. And what we really tried to do in the previous effort, which took place in 2018, was to delineate these these pathways, which we could simplify as much as possible for the management of peritoneal metastases. And I won't go into the specifics over here. We'll go over the updated pathway in just a few minutes. And this work, it was ultimately published in 2 journals in order to capture a wide readership in both the surgical as well as the medical oncologic domains. With regards to the current efforts, we are trying to update the existing pathways in line with major developments in the field over the last 5 years. And importantly, we are trying to support the evidence basis for the recommendations within the pathways using systematic reviews of literature. And the methodology that we're trying to employ in the guideline development process, we are trying to align it with recommendations for guideline development from major national societies such as the Society of Surgical Oncology, also known as the SSO, and the American Society of Clinical Oncology, better known as ASCO. In addition to the existing body of work, we are trying to advocate with patient support groups such as Hope for Stomach Cancer in order to, again, add a patient's perspective to the body of work and really try to be holistic in the way that we are developing our guidelines. So far, in the guideline development process, we have engaged over 200 physicians across the country and across various disciplines, and over 50 surgical trainees to help with some of the workload that comes along with this initiative. We are engaging with patient support groups and also trying to present our work to various national societies in order to try and broaden the impact of our work. So I will jump into the pathways next, and the methodology that we're trying to employ over here is known as a Delphi consensus. So a consensus is a consensus process. Basically, what it does is we present a set of recommendations to a group of experts across disciplines, and we try to see to what extent do they agree or disagree with the recommendations, and we garner feedback from the process and modify the recommendations. And then we present this again to the group of experts to see whether we are able to increase the level of agreement that we are engaging throughout this process in order to create balanced guidelines. So for our guideline process, we employ 2 rounds of voting. The first round for the Delphi consensus took place from June to September, and after we garnered these votes, what we did was we gathered all the feedback and discussed salient points which would go ultimately into the pathways and disease site working groups. And I must say, our gastric disease site working group has been particularly active because of strong proponents like Dr. Yanghee, Dr. Sam Klempner, and other surgical oncologists across the country, including Dr. Jonathan Greer at Hopkins, and Dr. Hagen and Dr. Timothy Kennedy at the Rutgers Cancer Institute, amongst others. So we are very grateful for the support that we have garnered in this regard. We have, in fact, consolidated the responses from the first round and modified the pathway in order to circulate it to the national group once again. This just happened last week, and we are in fact in the second round of voting as we speak, and we're hoping to consolidate all responses by the end of the year. So let's take a look at the gastric cancer pathway now. And for this specific pathway, we engaged a total of 141 responses from physicians across the country. And we've tried our best to simplify the way that this is arranged. And I have a feeling that a lot of the content that is over here has already been discussed in this meeting, but I will just try to summarize some of the salient points. So first, we are starting with a preliminary block which summarizes the major investigations that we will perform for a patient with stomach cancer with suspected peritoneal metastases, starting with a history and physical examination, followed by representative imaging and a pathology review. I'm sure the tumor markers as well as biomarkers were touched upon in great detail, so I wouldn't detail this any further. Importantly, what we have added in this iteration of the guideline is to engage with patient support groups as well as garnering support for fertility counseling and other means of support early on. We believe it's very critical to do this early on in the process. And that's pretty much the first block over here. And the next step, as we would all know, would be to examine the peritoneal cavity using a diagnostic laparoscopy. And the main purpose over here is to really assess the extent of peritoneal disease that exists. If there is no peritoneal disease, then we would continue to manage this in the line, along the lines of localized gastric cancer, which is out of the scope of these guidelines, and that's the small yellow box that's branching off over the top. And next, if there is peritoneal disease, then we would really like to see if there is low volume or high volume peritoneal disease. And in general, whenever there is extensive peritoneal disease, it is a poor prognostic indicator. This does not tend to respond well, not only to systemic therapies, but also to regional therapies. And in this case, at this time, we are recommending systemic therapies, clinical trials, and best supportive care, as indicated by the box branching off in the bottom. In the presence of low-burden peritoneal disease, and this to represent the extent of disease, we use a marker known as the PCI, or the Peritoneal Carcinomatosis Index. This is a 39-point scoring system indicating the volume of disease present across the sites of the abdomen. And really the cutoff that we have come to use is a point of either 7 to 10. So if there's a score below this range, we would consider it to be low volume, and this cutoff stems from various trials and studies which have been published over especially the last 5 years. So just proceeding forwards, in the case of low volume peritoneal disease or positive peritoneal cytology, as with any case of stage 4 gastric or stomach cancer, we would start with systemic therapies. Again, the details have been covered in some of the previous talks, and what we've tried to assess over here is whether there was a response or progression. And in the setting of progression with systemic therapy, that again is a poor prognostic indicator, and we might reserve the use of regional therapeutics in this case, but really the value and the potential for using regional therapeutics, namely CRS and HIPEC, it stems in cases which have low volume disease, which responds to systemic therapy to begin with. And over here we can see, and this is the critical part, the last blocks over here, blocks 5, 6, and 7, delineates some of the approaches we might take for this highly selected cohort of patients. In case a complete cytoreduction is predicted, and that would mean that we are able to remove all macroscopic disease within the abdomen, we would consider to proceed with cytoreductive surgery involving gastrectomy, as well as resection of all the involved peritoneal surfaces, as well as the administration of intraperitoneal chemotherapy. An additional alternative over here is before proceeding with cytoreductive surgery, one can go through serial cycles of laparoscopic HIPEC. So this would involve installation of the intraperitoneal chemotherapy within the abdominal cavity, either for a single cycle or for multiple cycles, in order to see if the disease is responding, if it's clearing out, or if there was positive cytology, if it's converting to negative. In that case, then we can further proceed with gastrectomy and excision of the involved peritoneal surfaces. And in case, based on shared decision-making, of course, if one would not consider it best to proceed with surgery, then we always would continue to recommend further systemic therapies and clinical trials. Now, and just going back to the first pathway, we received over 90% of consensus, so that would mean that amongst the 140 experts that voted upon this pathway, we received over 90% of agreement. So these blocks were voted upon either as strongly agreed upon or agreed upon by most experts, except this one block over here, block number 6, which was tweaked a little bit again to clarify the selection criteria that we are trying to apply here. But otherwise, there were no major changes after the first round of voting, and the second round is going on currently. Another addition to this iteration of the guideline development process is to be a little more descriptive with the systemic therapies that we would recommend as a group using in the setting of peritoneal metastases. And again, these have been covered just recently over the past talks, depending on the biomarker status. So I won't go into the details over here. And what we're adding along with this summary table for systemic therapies is the recommended regimens for intraperitoneal chemotherapies. Some of the common drugs are listed over here for HIPEC, mitomycin C being a very commonly used agent, along with platinum-based agents as well as taxanes. And there are also recommendations for agents to be used in PIPAC, which is similar to HIPAC, but it uses a pressurized aerosolized form of administering this chemotherapy in order to help increase the penetration of the agent and just involve the target the tumor cells within the peritoneum more effectively. And we also spoke about the alternative of administering intraperitoneal chemotherapy at a normal temperature, which would represent NIPEC, or normothermic intraperitoneal chemotherapy. So that, in a gist, would be the level of work that went into the gastric disease site pathways and systemic therapy tables. Similarly, this being a consortium effort, we are also addressing various disease sites. So we have 2 pathways for the management of colorectal peritoneal metastases, both synchronous and metachronous. There are 3 pathways for appendiceal tumors representing localized benign tumors, as well as appendix cancers and peritoneal disease stemming from these. Also, a single pathway each for the management of peritoneal mesothelioma, peritoneal dissemination from neuroendocrine neoplasms, and malignant bowel obstruction in the setting of peritoneal carcinomatosis. We are also trying to support the evidence basis for the recommendations in these pathways with systematic reviews of literature. And this process, briefly, it involves coming up with a targeted search strategy to surf online databases for existing articles, including major randomized controlled trials, as well as observational studies, and then filtering all of these articles and extracting relevant data from them, followed by quality assessments in order to assess the biases that are associated with this data. For the gastric cancer group specifically, we have 4 key questions which we are currently reviewing. The first one focuses on the role of regional therapies, namely intraperitoneal chemotherapy in localized but high-risk gastric cancer without peritoneal metastases, because in these cases, there is a higher risk of recurrence within the peritoneum. The second question focuses on the management of cytology-positive gastric cancer without overt peritoneal carcinomatosis. The third key question is perhaps the most important in the context of this guideline and focuses on the treatment of gastric cancer with peritoneal metastases using CRS and intraperitoneal chemotherapy. And the last question focuses on systemic therapies, including the ideal sequences and regimens of systemic therapies to use in conjunction with CRS and HIPEC for gastric cancer with peritoneal metastases. These are some of the landmark studies that we've encountered so far. There are quite a few, and I won't go into the details of these because they will show up ultimately in our guideline document, such as the Regatta trial, which was a multi-center trial based in Asia, the Phoenix GC trial, which was a multi-center trial in Japan, the GIMSA trial, which was one of the earliest trials from the United States at the NCI, and of course, some of the landmark work from Dr. Badgewell's group in MD Anderson with 2 phase 2 single-arm trials. And the second set of studies investigates the role of the addition of intraperitoneal chemotherapy to cytoreductive surgery to see whether there is an additional benefit. And there was actually one of the earliest studies which stemmed from China, and this one is more recent, the CytoGIP study. It's not a trial, but it is a case-controlled study where they were based in France, again a multi-center study, where they reviewed a prospectively maintained registry and identified some of the favorable prognostic factors for survival after CRS and HIPEC for gastric cancer with peritoneal metastases. And the most recent trial was the GastroPEC-1 trial, just published last week. And again, this was comparing cytoreductive surgery alone versus cytoreductive surgery and intraperitoneal chemotherapy. While it was negative in terms of the primary endpoint, which was overall survival, which was similar between the 2 arms, they did notice that there was a survival benefit, benefit in overall survival in the subgroup of patients who underwent a complete or a CC0 cytoreduction. And this was further reflected by a signal towards potential long-term survival in few patients in the arm who received HIPEC in addition to the cytoreductive surgery. And similarly, there was a benefit in progression as well as distant metastases-free survival in the arm which received HIPEC in addition to CRS. But I know I apologize for the busy slides. We will cover these studies in significant detail within the final guideline document. The layout for this, for which is as follows. For every disease site, we anticipate in the final document to begin with a summary of major changes that happened since the 2018 effort. This would be followed by a brief methodology of the guideline development process using a hybrid consensus and evidence-based approach, followed by block-wise itemized recommendations with relevant references stemming from the evidence from the systematic reviews, incorporated at relevant junctures within the guideline document, culminating with summary tables for systemic as well as intraperitoneal chemotherapeutic regimens. And lastly, this is what I believe is the most important addition, would be to garner patient perspectives and resources for outreach. And this is why we are here. We're trying to request for everyone's support in order to help write this culminating part of our guideline document. It again aligns with some of the recommendations from major societies and bodies which are involved with guideline development, such as the Cochrane collaboration based in the UK. So yes, we have engaged Hope for Stomach Cancer, and again, I'm very thankful for everyone's support with regards to this effort. And similarly, we have reached out to other societies also who have volunteered their time, such as LACNETS for neuroendocrine neoplasms, ColonTown for the colon cancer disease site group, the Mesothelioma Applied Research Foundation, and also ACPMP and PMP PALS for the appendix cancer and the appendix neoplasm disease site group. Two of the smaller objectives, I believe, from this consortium effort, which I would just briefly touch upon. The first one would be the educational piece, where we are trying to develop a standalone curriculum for teaching the next generation, as I mentioned, especially surgical residents, about the management of this complex disease process. We have engaged with faculty members across the country in order to delineate specific learning objectives after conducting a targeted needs assessment, and in the process of developing a curriculum which is going to be administered online across the country. And this is building upon some of our pilot work in designing and implementing a learner-centered curriculum for surgical trainees. And the last part is focusing on delineating standards for the management of peritoneal metastases, and this pertains to the structure and the quality of surgical treatment for peritoneal metastases, extending into operative reports and what points are important in the documentation of this effort, as well as standards of training, surgical training for the management of peritoneal metastases, and further translating into billing and coding and the documentation efforts, as well as the preparation of intraperitoneal chemotherapy. The major updates in the current effort are in the billing and coding part, and how we can accurately document the procedures performed, as well as care for practitioners, which we can definitely discuss at another time. But yes, I think I've taken a lot of time already. In summary, with regards to regional therapies for gastric cancer with peritoneal metastases, there is a growing body of evidence and definitely a lot of interest in this field. At this time, we understand that the potential benefit for this aggressive treatment is in a highly selected cohort of patients who have received and completed preoperative systemic therapy and have responded to the systemic therapy. They have a limited volume of peritoneal disease. We use a cutoff of 7 to 10 on a 39-point scale, and in whom all of the macroscopic disease can be expected to be removed as judged by the surgeon's expertise in this process. The next steps in this process were definitely first to advocate with patient support groups and help garner a patient perspective within the guidelines, extending further into advocacy efforts and engaging with national societies in order to broaden the impact of this work. And the long-term goal would, of course, be to promote research and create a platform where we can collaborate as a group, build registries, and paving the way further into innovative clinical trials. And that's the next on our agenda as a consortium group. This, again, is a summary of the efforts that exist within this initiative. I view it as a 4-level initiative with pathways, systematic reviews, an educational curriculum, as well as standards for the treatment of peritoneal metastases. This is, of course, a huge undertaking, and I feel very grateful to be a part of a largely trainee-driven team. Most of us over here our team is comprised of surgical residents and medical students. And Sam Yutinsky over here in the bottom right, he has been the driving force for the gastric disease site group. Unfortunately, he could not make it here today, and that's why I'm here on his behalf. And we are very grateful to benefit from the mentorship of Dr. Kiran Turaga and Francisco, who is now a surgical oncologist, and he was significantly involved in the prior iteration in 2018. I would like to thank everyone for the time. Please feel free to email me, Sam, or Dr. Turaga with any questions, feedback, or any comments as to how we can build on this work further. Here's a QR code on the website, which houses some of the information that I just shared. Some parts of it are password protected in line with recommendations from our journal partners, but we can set up a way in order to give further access. I'm happy to take any questions. Thank you.
Thank you so much, Dr. Bansal. If there are any questions, we are going to have to address it because I know there is a 5 o'clock, like everything's going to shut down at 5. So thank you so much. Thank you. And our next speaker is Dennis Watson from Trevera. Thank you.
Let's get our slides up here quickly. Excuse me. Hello. So I'm Dennis Watson. I'm with Trevera, and we are a startup diagnostic lab out of Boston, MIT, and Dana-Farber sort of initiated technologies. And I'm going to spend just a few minutes today giving a brief summary of the unique work that we're doing. And then we'll dig in tomorrow when we've got quite a bit more time with everybody. And I'll also be around all evening for questions and things. But I first want to just thank the whole group, Aki and Camilla and everybody that we've worked with up to this point to invite us here and bring this sort of to the forefront. We're doing really early work. This technology is primarily investigational. And most of what we're doing is in clinical trials and research. But we ran into a little bit of an unexpected happening when we got our CLIA certification, which sort of gives you the opportunity to offer a test clinically in the US. And that was that patients started to find us and started asking for our test and asking how they could get it. And clinical trials weren't always available in those settings. And then patients started talking to each other and started coming to us. And sometimes the data that they were coming with and the understanding they were coming with wasn't completely right. And so we started partnering with groups like Hope for Stomach Cancer to get the right education out there about what this is, but also what it's not. And so that's something that's very important to us as an organization, is being able to offer access to the test when it makes sense, but also being very transparent about where the data is and where the technology is today. So like I said, we're going to spend a full hour with you tomorrow. In fact, one of the developers of the technology and founders of the company is going to be joining me to enjoy that talk with everybody. But we've gone through the guidelines a lot today, and you guys have seen this presented in a lot of different ways. And I think it was Dr. Wu who said, when you're early stage, when you're newly diagnosed, when you're stage 1, it's pretty clear. We follow the guidelines. But for patients that get beyond that point, you get to a point where there isn't as robust of data to guide your care. You get to the point where the questions become not quite so clear. And that's where opportunities can come through clinical trials and additional diagnostic testing to provide more insight, more information about what might come next for you. You guys are familiar, this is just a single page from the guidelines. There are lots of pages like this. We are a pan-cancer test, so we work across basically all carcinoma, but we're doing a lot of work in gastric and in GI and gynecologic malignancies right now. And what you see if you're a patient is pages like this that have a lot of options on them. And the question isn't always clear on what comes next, right? And so I've sort of spoken to that already, but if you're that patient and you find yourself in this spot, this is where things start to get a little bit unclear and a little bit confusing. So this is kind of where Trevera comes in with our rapid therapy selection technology and what we're trying to do with our early data. Unlike genomic guided therapy and genetic guided therapy that a lot of the presenters have talked about today, those all require genetic mutations and markers that not all patients have. And so sometimes additional information can be sought through unique technologies like ours, and this is really kind of where we come in. Any patient that has viable live cancer cells through a biopsy or a fluid drain, if you have ascites, for example, can actually participate in what we're doing. So it's actually pretty simple. We work with you and your physician to start by getting a sample. And it does require a live cancer cell specimen. So that means a fresh biopsy, a fresh fluid drain, what have you. But we provide the kit ahead of time, ahead of the procedure. The doctors have that with them the day of the procedure. They collect that specimen, they drop it overnight in our special shipping kit to our company that's located in Boston. And once we get it, we extract the cancer cells, and we then link them to up to 20 different drugs. So we're going to get into this in a lot more detail tomorrow, but this type of testing is known as ex vivo drug testing. It's been historically called chemosensitivity testing. We don't like to use that word because chemosensitivity testing has a long and storied history that we're going to get into a little bit tomorrow. But our technology is very novel in the way that it has approached this problem that exists in treatment today. And we're actually the first technology that exists, at least to my knowledge and any of my colleagues that I work with, that is measuring the drug sensitivity against the patient's direct cells. One of the biggest issues inherent to chemosensitivity testing and those types of tests in the past is that when you take a cell out of the body, you're removing it from its life source. You're taking it out of that microenvironment. You're taking it to an environment where it can no longer be fed, and so it dies. It dies pretty quickly, all by itself. But most therapies that are used take about a week or more to work. And so you have this issue where the cells die faster than the drugs can kill them when you're in this sort of artificial environment. And so historically, what we've done is we've grown the cells. We get the specimen, we grow what they call organoids. We've done it in mouse models or PDX. They've done it just with basic cultures. They've approached it in a lot of different ways. The problem with all of this is that cancer, as you have all learned through your care, I'm sure, is a mutant. And when you intervene with a mutant and you take it out of its environment and you pump it full of cytokines and proteins and growth factors and all these things to get it to grow artificially, it often changes. Doesn't always change, but it often changes. And the problem is that the researchers that are doing the testing of those drugs don't necessarily know if these cells have shifted or not. And so what makes Travera's technology very unique is that we are getting those cells, we are testing drug against those cells all in about a 48-hour period. And so if you heard me a minute ago, I said the drugs take a week or more to work. So that's been the conundrum. So unlike previous generation technologies, instead of waiting for the drug to kill the cell, we're actually waiting for the drug to change the cell, which happens very rapidly. And we do this with a new measurement technology that was developed at MIT. So it's actually a physics-based approach. And as I said, we're going to get into a lot more detail of it tomorrow. But the idea is that we're weighing individual cells. We're taking cellular mass. And we're taking cellular mass to a level that is about 100 times more precise than the next best technology that exists today. Without getting into all of the specifics for you right now, we can recognize the change in mass of an individual cell that would be equivalent to that cell losing about 5 nanometers of diameter. If any of you had a freshman year physics class, the average wavelength of visible light, a single wavelength of light, is about 400 to 700 nanometers. So we're able to recognize the change in mass of an individual cell that's 100 times smaller than that. So it's an incredibly precise measurement technology, and the reality that we've shown through our work with MIT and Dana-Farber is that when a cancer drug works on a cell, it changes the cell. It kills the cell, right? I mean, the whole goal is for it to kill that cell eventually. And so when a cell changes, its mass changes. And this is the first time that there's been a technology that's sensitive enough to measure that mass change at such a small level that we can see it very rapidly. So this whole thing happens in about 2 days. As I said, we get the cells and we weigh them. We get that data. We turn it into a report for your doctor. This all takes just a couple of days. Again, it's important to understand this data is very early. It is not right for every patient. It's not right for every doctor. We're trying to do as much as we can in a really controlled clinical trial environment, and we do have clinical trials available that really anyone can enroll in with very broad criteria. And we're always happy to push people that way. We're also always looking for more research partners in the medical community. But we also have this early access program for patients that might not fit that criteria for one reason or another. And through groups like Hope for Stomach Cancer, we're able to offer the test at no cost. We're just looking for the continued experience and continued validation with the understanding that there's a lot that we don't know yet. So far, we've got full outcomes data on about 60 patients that got the test, received one of the therapies we analyzed, and then we saw clinical response data as to whether or not that worked in them some months later. And so far, the predictive accuracy of the assay is sitting at about 84%. So incredibly high for patients that in most cases are on third line or later therapies, where it becomes really difficult to find what drug is going to work next. So that's kind of the concept of all of it. The report looks a little bit something like this. It comes back to your physician showing, I think there's a button here, the drugs that are sort of sitting here at the top are the drugs that were highly sensitive in those cells. The drugs that are sitting down here on the bottom are the drugs that really had no response at all. And as I said, tomorrow, one of our PhD developers is going to go through more of how those measurements are actually taken and how this translates into clinical outcomes. But the idea being, you have a long list of drugs. We do 20 drug panels on average. And so this is actually an example of a lung cancer case, but we then stack rank the drugs of how sensitive they were or weren't, helping the doctor to make better decisions on narrowing the scope within classes of drugs that they're already considering. The goal here is to not offer up some crazy drug that the doctor would never use otherwise. It's about taking the list of drugs that are already in sort of the standard purview of care and saying, these drugs were highly sensitive in these cells, these drugs did virtually nothing in these cells, and it helps to better guide that decision-making process. And as I said, we've got right now above 80% predictive accuracy on really both ends of this. It's called negative predictive value and positive predictive value, meaning that when patients in our clinical trials got one of these drugs that we said wasn't going to work, it didn't work. They continued to progress through that drug, versus patients that got one of the drugs that we said was going to work, and then we did see a clinical response in those patients, measured in lots of different ways that we won't get into the details of right now. But that is essentially the concept here. As I said, we have clinical trials. We'll get into a lot more of this in more detail tomorrow. But if anybody is interested in getting more information and getting access to one of the clinical trials and getting access to the test, all you really need to do is email me. Again, my name is Dennis Watson. That's my email address there on the top. You can also call. That's a voicemail number that comes directly to me. But I'll also be around. I've got cards. I've got flyers. I've got other information. And I guess that's it until tomorrow. Yeah. Sure.
So I don't know when I'll get my next exploratory lab.
Yeah, we don't know right now. I mean, we're probably for at least another year, is our goal. Yeah, no, I understand.
This gives me an idea.
Yeah.
How much pressure I need to apply to a doctor.
Yeah, and you know, and we're doing a lot of work in the space of HIPEC too. That's another topic that's come up quite a bit. We're working with a lot of HIPEC physicians. One of the challenges of HIPEC today is that there's pretty limited drug options available for use in that way. And so there's a lot of interest in the rapid turnaround time that our assay has and the ability to really show sensitivity against the cell. That might be really nice applications of finding better drug options or more drug options for a HIPEC type approach. Great. Well, as I said, I'll be around all evening. I'm happy to take questions and talk with anybody directly, but I know they're trying to get back on schedule. So, and we'll be here tomorrow morning to get much deeper in a lot of this as well.
Thank you so much, Dennis. And our last speaker, save the best for last, is Diana Abacera. I hope I'm saying your name right. And she is from Lille.
I'm from
Health.
Lille Health, yes. Hi, everybody. It's so good to see all of your familiar faces. Okay, let's see where my deck is. Okay, bear with me, please, because I had to do this in a PDF. Okay, great. So hi, and I'm the last speaker. Thank you for hanging in there. It's been a great day. I'm Diana, and I'm here to talk to you guys a little bit about Lille Health. We are a startup company in the field of precision medicine. And as I take you guys through this, I want you to remember one important thing. We are a company built by cancer patients for cancer patients, okay? Okay, next slide. And how do I do this? Here we go. So just a couple of words on our origin story. This is Svea. She is incredible. This woman was out running the world in New York City. She is a pretty big global business exec, and she was living her life, having her family, and in her early 40s, she was diagnosed with stage 4 melanoma. Now, for her, anything but living was never an option. She had 3 little girls at home. The youngest one was 1-year-old. So Svea went and to our local oncologist in and around New York City, and she was given the standard of care. And it worked, and then she went into remission, and then it came back. And she went through this a couple of different times until she decided to do something that was basically in her wheelhouse. She decided to do some research. So she went on clinicaltrials.gov and was absolutely shocked with how little she understood. And that is because websites like clinicaltrials.gov aren't meant for patients. They're meant for scientists and doctors and oncologists and people who know the acronyms and understand the studies. And she didn't quite get what she was looking for. She found one study that she thought was interesting, and she took it to Memorial Sloan Kettering to her oncologist. And he said to her, you know what? I've never heard of this study. It might work for you, but I can't put you into this study because I don't have a seat in that trial. So she went home and she said to her husband, I cannot believe that in today's day and age, there is not a platform that can match cancer patients with the clinical trials being designed for them with ease. And he said to her, there's nothing that exists like that? And she said, no, but I'm gonna build it. And she did. She built Lille Health, and she went into the clinical trial, and she saved her own life, and she's been NED for 4 years. Okay, so who are we? We are a completely unbiased, patient-first AI technology platform. We work with all the stakeholders, everyone from the patients to biopharma to healthcare providers, and our main goal is to give everyone access to clinical trials. Our mission is to empower every single patient in their cancer journey, and we give you information, we give you education, and most importantly, we give you access to every available clinical trial at every point in your journey. Very simple. How it works is you go to Lille Health, the website, and you fill out what cancer you have, and then you're presented with a dynamic, personalized questionnaire. And what's unique to this questionnaire, and what we mean by dynamic, is you start with a funnel approach. And the more information you feed into the system and into the questionnaire, the more precise your match list will be. Once you fill out the questionnaire, it takes a few minutes, less time than it does to fill out the paperwork in a doctor's office. You instantly receive a list of your precise trials that you've been matched with. And then you take those trials and you go to your oncologist, and together you decide on the next best steps. So we always say that we're a patient-first company, and what that means is the patient is at the heart of everything we do. We're completely private. Everything's 100% HIPAA and GDPR compliant. Unlike clinicaltrials.gov, we have created every piece of content, every email, in a format and in a language that every patient can understand. There's zero trial bias. You're never presented with a trial match that's not exactly precise to your clinical diagnosis. Our platform is not constrained by your location. Patients can decide how far or they would like to travel for their treatment. We have an incredible patient engagement team that walks the patient and educates the patient about their options every step of the way. We understand all the patient barriers because we work so much with the patients. We understand medical mistrust, insurance issues, transportations, and so forth and so on. And we work directly with the patient one-on-one to resolve those pain points. And finally, and this is something that is something I've learned recently, that oncology drugs is a massive business, billions and billions of dollars. And also a cancer diagnosis is one of the leading causes for bankruptcy. So all that taken into consideration, our services are always 100% free to our patients. There's never a cost. I'll run really quickly through this. How do people find us? Where do we educate you? So basically, we're everywhere the patient is. We're on social media, we've got commercials running, we're on radio. We create all of our original content we create ebooks and blog posts, we have original webinars. So we're not that hard to find, you just need to know about us. A few key achievements, I will focus on the recognized by section. When this platform was developed, Time Magazine recognized it as 100 of the most innovative companies. And you can see on and on. Fast Company, we were one of the changing the world ideas. We work with 8 out of the top 10 largest pharma companies and 65 of the smaller oncology-focused biopharmas. And we have a list of awesome partners that we are working with, Stokan, one of them. Happy to announce that we are in partnership with Stokan now, and our clinical trial finder will be embedded on the website within the coming weeks, maybe month. So you can have all the clinical trials at your fingertips. And this is actually our team. These are pictures of people that we work with, just so you can see who you're working with. Right now, we're running about 82% female. We sit across 5 different countries and 3 continents. We have 9 different languages we operate in. We've been published in over 65 clinical publications. And then in terms of our experience level, you can see we've got nurses, PhDs, social workers, oncologists, and most importantly, we've got cancer survivors. So a combined experience in healthcare, about 240 years. Our patient community, so in the last 4.5 years, we've grown to about 160,000 patients. We're growing at a rate of about 4,000 patients, new patients a month. 35% of those represent minority populations. We're really excited and proud of that. And then 75% of that live in rural communities that have issues with access, many, many barriers we're trying to address. 25% of our patients actually enroll in clinical trials, which is astounding considering that the industry standard is about 2 to 3%. The reason is that we have that incredible patient engagement and clinical team that basically shepherds you through the entire process. They answer your questions, they help you figure out how to speak to your doctors, so forth and so on. So you're never alone. Each patient on average gets 4 hours with at least one of our clinical team members. Okay, a little bit of bragging. Patients actually who've used us really feel empowered, feel like they're part of their journey. One of my favorite quotes is, "A patient needs to restore their hope in order to restore their health, and you have helped me restore both." She's one of the first people I met when I joined this company. Even doctors are actually supportive of what we're doing. We're trying to work with them, not cut them out. If anyone knows Dr. Lin, he's the former Chief Medical and Scientific Officer. He's also one of our advisors. He says Leal helps oncologists and patients make the best decisions in regards to clinical trials. We've got many other doctors who would agree. So for us, it's personal. I had a video to show you. It didn't make it in here. But every person in our company has been touched by cancer in some way, myself included. I am an 18-year breast cancer survivor. I was given the standard of care 18 years ago. I wasn't given other options, and I didn't know to ask about other options because I was 32. I got very, very lucky, but a lot of people don't. And I wish that I would have had this as an option when I was sick. I probably would have suffered a lot less. But regardless, I'm grateful to be here talking with you. And Rachel and I are going to be here tonight actually as well, but tomorrow for an hour, we're going to talk about stereotypes and myths surrounding clinical trials. We're going to do some Mythbusters. We're going to show you what empowered patients look like, and we're going to have some fun. So please join us early, 8:30. Thank you.
Thank you so much, Deanna.
You are welcome.
And I'm sorry I said Diana earlier.
It's okay, it's misspelled.
Thank you so much. And with that, Dr. Wu, I will hand the microphone to you.
So are you guys inspired? Okay. I had to go change because I hate being in a dress, as most surgeons like to be in scrubs. But it was a very amazing and inspiring afternoon for all of us. I'm so happy that we got to hear some amazing talks by medical oncologists and the industry team. We're about to close out tonight to go to the other room, I think, for, are we partying? Is it dinner, cocktails? What are we doing, Aki? Just dinner? And conversation. So all the questions you have, in your legal yellow pad, please ask away. Thank you, everybody.